Steve, if you're ready for us. Welcome to the 148th meeting of the Board of Directors of Oxleas NHS Trust, and welcome to everybody. Welcome to our governors as well, and all our members of staff and our non-exec directors. Sally, do we have any apologies for absence?
Yes, we have apologies from Anne Basu and from Neil Springham. I'm not sure whether, Patsy, are you here on behalf of Neil or for another item?
Yes, I'm here to represent Neil. Thank you very much, Sally.
Welcome, Patsy.
Aye.
The minutes of the last meeting we have circulated, and we have had some amendments. Sally, do we want to go through those amendments?
Yes, I'll just quickly summarise them. So we have several amendments from Joe, which pick up particularly on page 2 and the second line, changing to the CIP target 13.5 million. Picking up a couple of typos which we can correct. And on page 7, item 15, the fifth line, we added a sentence there to make that make more sense, changing to additional funding to cover sickness levels, and noting that the Greenwich Spa visit was Joe's rather than Steve's. The initials have got crossed over. And then Azra has made the following corrections. So section 4, paragraph 4, the first sentence should read, we need to cover costs with income or reduce costs recurrently in order to increase contribution. And in the section 4, paragraph 13, the sentence should read, this risk was fully mitigated in year, but is clearly going to be an ongoing risk with a new ICS financial arrangement. And in section 15, the sixth sentence should read, it was noted we're still examining the retained services funding from NHSE. And I'll make sure that Sue's got those corrections so that we can therefore update the version for the records. Thank you.
Thank you for that. Thanks for those people who found those. But we'll go through the minutes and any other matters that people wish to raise. We'll go through page 1, page 2, page 3, 4. Suzanne.
So I'm just curious, Andy, because I sent some corrections through to Sue. So are there other corrections which Sue has incorporated which weren't mentioned under Sally's?
Yes, the earlier corrections will have gone into the minutes that went into the pack.
Right, okay.
Have they been dealt with, Suzanne? Have you noticed that? Have they been amended?
Well, I didn't read through them again, having read through Sue's draft, because I assumed that they were the same ones. So
we can double check.
I think they may be in the part 2. I think the corrections Suzanne raised may be in the part 2.
Well, there were some in part 2 as well as part 1, but I'll present.
Okay, thanks, Rachel. That's page 4, page 5, page 6, page 7, 8 and 9. So subject to making sure that Suzanne's have been incorporated, then we'll take that as a record. Matters arising. There are 3 there that are now closed. The health and safety will crop up, and that should be apprised, shouldn't it, rather than appraised in the action details. So that health and safety will crop up today, won't it? CH investigation report. It's got board assurance framework on prone restraint. So this is now closed. Does this, where else is this cropping up for us to keep an eye on?
We're having a seminar next week on restraints, exploring the different options. Right,
okay. Now, I presume that comes in through PQAC as well, the MSC?
Yes, that's right.
Yeah.
Yep, so we keep an eye on that, and that's in our reports.
Okay, fine, thank you. So subject to anything else on that, board assurance framework. Matthew, any matters? We did have a really good go through this one by one last time. I don't intend to do the same again, but Matthew.
Thanks, Andy. There's a couple of updates. I mean, one of the actions from last time was for all the subcommittees and relevant parts of the executive to review their own risks. So we had two changes that would have happened anyway, which was around ligature risk management. And I'll mention later the CQC report, but we've reduced this is a low risk, and also the impact of COVID on staffing levels, which was reduced and tolerated due to the way in which we're managing it. And what you can see in the covering sheet is the way in which we are reviewing and updating the range of other risks through the usual committee process. So for some of them, they have already changed. Some of them will change once, for example, Business Committee, PQAC and others have worked their way back through that process. So the register as a whole is much more reflective of the discussion we had. When we see it again in September, the subcommittees will have completed their review of all the relevant risks.
Yes, okay. Any questions at all on the board assurance framework? Jo?
Yeah, just very briefly, on the added risk about ligature risk management in prisons, it refers to an incident at HMP Lewis. Could we just have a very brief summary of what that was about?
I don't know, so I'll have to look to someone else.
Email's fine, Matthew, thank you.
Yeah.
There is a national report, so I can circulate that to board members if they're interested.
Yes.
Yeah, that'd be helpful, Sally. Thank you. And anything else? Stephen Dilworth, please.
Yeah, just checking in with Rachel C and Matthew on 1471 staff experiencing discrimination at work. Are we confident that that all issues of violence and aggression are being reported? I'm just worried about people getting used to a kind of new norm. I know we've asked this before, so it's a continuing assurance. You know, we don't want staff to be any sort of be subject to any sort of mild attack, let's say, which isn't being reported because they think it's just part of the job.
I'd like to on that one, Andy.
Yes, please.
So, Stephen, we've got a internal audit report actually looking at this at the moment, and Jane Wells and I met with them this morning to hear their preliminary findings about how that's being approached. It does seem that we have good levels of reporting on Datix about incidents against our staff, and those kind of capture quite a broad range, both the really serious incidents where there's been intimidation or violence, but also some of them more at the other end of the scale as well. And what we want to make sure is that we've got the right support in place for all staff after those incidents. So we're raising the profile of the It's Not Okay work about the flow charts, about how to make sure that people know exactly the support that they can access. But we're also meeting on a 6 weekly basis with the police to make sure that we are following up on the more serious incidents. And we have some really good quality improvement projects which have managed to deliver some 40% reductions in violence and aggression on some of our wards. So there's quite a lot of activity going on in this space, and it feels as though we're making moves in the right direction. Staff survey would support that too. I would say that things are getting a bit better, but it's not. There's no scope for complacency. We want to keep really working on this.
Thank you.
Okay, thanks very much. If there's nothing else on that, we'll move on to you, Matthew, for your Chief Exec report, please.
Okay, thank you, Andy. Okay, so folks, the report's in the pack as ever. Just scroll through the BAF to get to it. Right, okay, so a couple of points to raise this month. First, COVID, it's ongoing, isn't it? And we know, I think we'll all have read a lot about the Delta variant that's out there, and it's positive, I think, that so far the link between the case numbers, which are very high at the minute, but also between that hospitalisations and deaths, the link there seems to be moving much further apart in a positive direction. And I think what we're be looking to see over the next couple of weeks is how that sort of creeping number of hospital admissions just pushes up. Within our own patient group and workforce at the minute, there's very small numbers of possible suspected COVID, despite extensive testing ongoing as well. And we're continuing to encourage and support staff to have the vaccine and offering advice to those who are worried about it. But we are very much into that variants versus vaccines sort of mindset now, really. And I think at the moment, the pressure on services is predominantly non-COVID related demand. It's that huge pent up sense of demand that I think Ian will talk more about in his operational report, with COVID moving more into this kind of endemic phase where it'll be something that we've got to deal with as part of everything else that's presented around the NHS just now. So I suppose the only thing is that hospitalisations and deaths are lagging indicators. They're things that indicate pressure after the event. Because of the vaccines, they dampen some of the earlier and leading indicators, which are things like 111 and GP calls. So it does mean we're in a position where it's slightly harder to respond to the sort of front wave of new infections. But I think the testing numbers are really pushing up, and I think we're seeing happen what we'd expect to happen with a majority vaccinated population, which has got to be positive. We had a follow-up CQC inspection of our older adults mental health inpatient wards in April. This was after we'd received a warning notice for the way in which we're managing the risk around ligatures in December. And I think older adult services have really been through the mill. They were very hard hit by COVID early days. And, some of the wards have had to deal with a really quite significant impact of that on their patients and on their staff. And I have to say that the service has responded in the way, as well as we could have expected from them, working with teams like those of Vicky Ellis and Jane Wells to really make sure that we took to heart what CQC had raised concerns about. And I think if you've taken the time to read that report, and if you haven't, I'd encourage you to do so. There's really strong sense in there that we've got that culture of learning right, and that we've managed to make that connection from board to ward in terms of our oversight of the risks in there. And the quote from Jane right there about it being a very positive report. And in my conversations with older adult staff recently, I think they're keen now to get a full inspection, because I think some of the content in there reflected elements of an outstanding service, and I hope that can be our aspiration for older adults for when they next get inspected. We also celebrated the anniversary of the launch of our Building a Fair Oxleas work. I wrote to all staff, I think, on 8th of June 2020, saying we needed to take very seriously what we were hearing from staff about the impact of Black Lives Matter at the time, and we've since seen the massive impact that fairness and inequity has had on people through COVID. The fact is that people from more deprived economic backgrounds have caught COVID in higher numbers, have become sick in higher numbers, and have died in higher numbers than people from wealthier economic backgrounds. And that because of the way in which racism and discrimination affects the life chances of people from ethnic minorities, that burden has fallen unfairly on them. We've had a huge push within Oxleas really to get to grips with this through Building a Fair Oxleas, with thanks to Rachel and Iffy and others who've really been championing this piece of work. And there's information unpacking some of those real gains we've made, both in terms of representation of people from ethnic minority backgrounds at senior levels within the trust, importantly within the Band 8 roles as well, and Band 9s, and also the work that we're doing with groups like the Shadow Executive and the Building a Fair Oxleas Action Group and our existing staff networks to really address issues of fairness at work, and with a large training programme rolling out across managers at the minute to improve our understanding of that. And we're focusing on managers because managers recruit and appoint people, and the way in which we recruit, appoint, support and develop our staff is critical to making sure that we reflect our workforce right throughout the organisation. And I think this is this longer term will be culturally more important for Oxleas and for the NHS probably than COVID, what it's brought to the surface in terms of the longevity of people's experiences of discrimination in the health service. And so we do need now to start to focus more broadly on different aspects of diversity, people with disabilities, lived experience of mental illness, and LGBT plus staff. We've unashamedly focused first on issues to do with race, but we do need to broaden that out to make sure that all of our staff are able to feel as though they are respected and treated fairly in the workplace when they come to work for Oxleas, because we know that will bring out the best in them and bring out the best in us as a caring organisation. There's an update in the board papers. We'll talk later on health and safety, to introduce a health and safety oversight committee to support implementation of our strategy on that, and we'll talk more about that later today, and that will now be a standing part of the Chief Exec updates to the board. And then a couple of wider developments. We had a good event about South London Listens with colleagues in the SLP, talking to local authorities and community organisations about the impact of mental health on COVID. And there'll be some work coming out of that. And it was great to hear some voices there that I think we don't often hear in our dialogue with patients and service users and staff. And the work that Neil Springham and his team are doing on involvement, I think will really start to bring some of that to life over the course of the next year or so. And finally, you can't miss that we're in the process of not just getting a new chief exec for the NHS, we've also had a new Secretary of State, and we'll also be getting probably a new NHS Act at some point next year, once the bill comes through, to tell us how ICSs are going to work. And lots of us are spending an increasingly large amount of time and, you know, the sort of quiet brain function that ticks away in the background, trying to figure out what it means. You know, to have a South East London integrated care system that brings together health and social care partners, to have a really strong voice and representation at place level for community and primary care services and others, and provider collaboratives delivering powerful networked care, and in between all that, figuring out what the role of the trust is and how we deliver our accountabilities as an integrated board and as a healthcare provider in the context of this new bill. And I think it's fair to say there was relief to see that the 2012 Act, with all its big emphasis on competition, which I think our experience of has largely been harmful, you know, in terms of our core services. But I think, you know, what we're now seeing is that actually no reform, no structural change in the NHS is without its impact. If we can seize the best of this and really seize the opportunity to start to invest in public health, to invest in population health over multi-year cycles, and to break down the barriers between primary and secondary care and social care and what happens in hospitals and others, there's some really great prizes to be had. I think one of the risks is that we just possibly re-entrench some of the separation of systems that we already see in our current structures, and it's incumbent on us as a leadership group to make sure that we work with Richard Douglas, Andrew Bland and our colleagues in Lewisham and Greenwich Trust and others to really bring the strength of partnership to the fore as we enter this new era. And I think the kind of partnership work that Oxleas is known for is a huge asset in this time. You know, the strength of that partnership with Lewisham and Greenwich, the partnerships we have with the voluntary and community sector. And actually yesterday, Abby, Tom and I were talking to one of the South East London governing body GP leads about how we work better with primary care to break down some of those barriers and frustrations that exist between us and those primary care networks and those other critical local care providers. You know, so it's going to be, you know, these are hard things to do because it's such a big and complex and complicated system. But if we can move away from this annualised cycle and start to think about longer term investment in the population of our health and in the places they live, then there's a prize there to be had. So we'll be watching the appointment of the chief exec and others with great interests. But as ever, so much of the longer term direction, this will be influenced by how we maximise those local relationships. And Oxleas is a trust with fantastic tradition for partnership and local place working, I think is well placed to take on some of those challenges. And that's the main updates from me, Andy.
Thanks very much, Matthew. Firstly, can I just add my congratulations to everybody involved in the work on the older persons and the ligature points. I think it really showed proper grip and leadership and some great work on the ground, and I certainly saw it when I did my tour around, just how much work had been done there. So I think really well done to everybody on that, and well done on building a fairer Oxleas. There's the standard thing we always say of much more to do, but very, very good work, I think, and it's a great start. Suzanne, please.
I was wondering, Matthew, just going back to the beginning of your report, whether you might be able to say a little bit more about planning for COVID as an endemic disease rather than a pandemic, because I think I can absolutely understand that the acute sector is sort of beginning to breathe a sigh of relief as that connection between infection and hospitalisation is broken. But in many respects, that's not going to have quite the same impact on us, because our inpatient wards are still going to have to deal with patients who are probably susceptible to infection. And it's going to continue to affect our community services. And I'm just wondering if you could say a little bit more about how, as a trust, we're developing a strategy to deal with COVID as endemic.
Yeah, I mean, it's interesting. At the minute, acute trusts, I think, across the country, acute physical health trusts are reporting record levels of attendances. And primary care is also reporting enormous pressure, both on walk-ins and phone appointments. And we're seeing it within our mental health crisis services, also in all of our other physical health services, children's services, etc. There is an enormous amount of demand on the health service at the minute, a small proportion of which is COVID, but the vast majority of the additional demand is not COVID related at the minute. Ambulance services have been seeing record levels of call-outs. So right across the NHS at the minute, I think what we're seeing is the impact of 15 months of people not receiving routine care, plus the impact of the trauma and the experiences people have had during the pandemic. And I think you start to play COVID into that as a position where it takes up several thousand beds during its worst phases, which are likely to be in winter because it's a respiratory illness, and it goes into the mix alongside flu, by other contagious diseases before we got to the stage where they were controlled. So I think at the minute there is a sense that we need to maintain some of the real advances we've seen in things like the Home First programme in Bexley and Greenwich, where we've massively reduced the number of people who are waiting in hospital to be discharged home. And we're actually reducing things like demand on intermediate care beds and so on, and really enhancing that element of our community. At the minute, right across the NHS, I think we're not able to offer services in a timely way because the pressure on services is such, the demand is such at the minute, that whether it's trying to get a GP appointment, whether it's waiting in ED, whether it's waiting for a procedure, a surgical procedure or similar, whether it's waiting for your first appointment in the community, we are not able at the minute to match the resources we have with that demand. And I think even if you took all COVID demand out right now, Suzanne, that would still be a problem for us. And so one of the things that the Chief Exec of the NHS is going to have to do is to deal with the upcoming comprehensive spending review and look at what the resource settlement is for the NHS for this, and whether we decide that the NHS is just going to be in this position now for the foreseeable, where we have to cope with too much demand and not quite enough resources, or whether there's a workforce strategy that starts to address some of this in the longer term. Because for this winter, I think our planning is very much in the our business continuity plans and the way we manage the gold structure, etc. As a trust, we cope relatively well, I think, with the ways we've had to so far, and we will use the same structures and same processes to get through the next 6 months. But I think there needs to be, in the context of this reform of the NHS that we're seeing, a fairly fundamental reset of how we think about demand over the next 2 to 5 years, both bringing through some of the innovation of services. We've seen enhanced use of digital and others, a move away from dependency on buildings for services where we don't necessarily need them, but also to think about the workforce we need to deal with this, because if this level of enhanced demand, 10-20% more than what we saw pre-pandemic, becomes what we should expect, including surges of COVID and flu and children's respiratory illness and whatever else in amongst that, then we don't currently have the tools as a system to deal with that. And I think it's going to be a hard ask for the new ICSs are going to be born into this very resource constrained and staff constrained environment, and it's going to be a real challenge. So I'm not worried operationally about our ability to deal with COVID this winter within Oxleas as an endemic surge demand, because we do that well. I am much more concerned about what the next 2 to 5 years looks like in terms of dealing with this sustained huge increase across every single aspect of healthcare services. Ian might want to say a bit more operationally in his update as well about that, but our gold structure works well, I think.
Thank you, Matthew. Azra, please.
So I think it's just expanding on the piece that Matthew touched on at the end. It's around the COVID and about the infection control environments and what we're going to then rebalance, both what the provision of service looks like and what the way that we're going to have to operate going forward. Because although it hasn't been an issue for this trust, there have been other trusts that, due to infection control, have got an ongoing increase in their cost base in order to keep the distancing correct in their environments. And it's a piece of work that we're going to be looking at for the H2 planning cycle to begin with, of how we think the COVID costs are going to adjust. And that will then, I think, feed into that longer medium term environment. But it also then picks up some of the themes that Ian's got within his report, which talks about landing on some of the service provision that we've got and some of the new ways of working in terms of how we would address some of those. And I think it is wider than the back office. It is really about provision of service as well. So I think it's landing some of those probably a little bit sooner rather than later to allow us to be able to do the financial structure that we would need to have in place over that medium term. And it's bringing it all together. And I think that's going to be the real challenge for us over the course of the next 6 months, I would say, because we'd have to plan for whatever that future looks like.
Thank you, Ezra. Matthew.
Yeah, I mean, I didn't pick up that point enough, did I, Suzanne? Because I mean, the thing is, we know how to deal with infectious incidents in units. You know, we have norovirus, we have flu infection controls, we have protocols for the management of that. And I think, you know, Jane and her team have got good, tight IPC measures in place, and we just need to keep people very focused on it. As Azra says, managing it's going to be more expensive, and actually, depending on some of the national guidance, it does affect how many beds you need, how many patients you can get into a unit. You know, I mean, we're in the advantage that we're not in an environment where it's bays predominantly, you know, apart from in Eltham and Meadowview. You know, lots of our units are single rooms, which does help with that, although the bathrooms, you know, there's all the technicalities of that. I think it's longer term, what does it look like? And also there's something about the emotional impact on staff of having to work in full PPE. You know, we're in a circumstance where people are double vaccinated, they're taking lateral flow tests every day, which now increasingly seem to be sensitive to to infectious COVID rather than PCR tests, which can pick up lots of non-infectious COVID. And I think just the impact it has on the caring environment when you walk into somewhere and everyone's faces are covered. And there's all those difficulties around interactions as well. So I think, you know, there's all this stuff sort of rumbling around in the background as we think about what happens. And some of the national guidance will be very important on this. I mean, I suspect the public might be able to stop wearing masks at some point this summer. I don't expect our staff are going to be able to stop wearing masks for quite a while yet when they're in the work. But certainly when they're in inpatient care workplaces, and that's a difficult dynamic to play into.
I'll just briefly respond, Andy, because I'm really glad that Matthew picked up and Azra picked up those points at the end, because that was really what my concern has been. Is you know, that we, if I think about our inpatient staff, they've worked unbelievably hard to get through the pandemic phase, and you know, there are lots of issues that, you know, became apparent around the difficulty of getting bank staff who didn't want to work because of the risk of infection and so on. And, you know, my concern is that if we recognise that the Delta variant is highly infectious, it's not going to go away. There are going to be pools and pockets of COVID existing that we're going to have to learn to live with. And for my part, I think I would kind of value an opportunity to say, okay, this is how we think things are going to look differently for at least the next 3 years, recognising that our staff are exhausted, there's not going to be any let up, that we're going to have to continue to deal with infection, and you know, there's going to be the additional work in doing a booster vaccination campaign and so on and so forth. And so, I mean, those are the sorts of things that I've been thinking about, and maybe Ian might like to pick that up again in his coup report.
Thanks, Suzanne. Iffy, please.
Yes, I did put my hand up and then put it down. So I kind of wanted to mention the booster. So currently we know that a little over 80% of our staff have had the first, 60, close to 70% have had the second jab. And you would have heard that the government's intention is for over 50s to get their booster. So this is probably going to come at a time when we'll also be trying to get flu jabs into our staff. So there's something to be said about getting over 50s who are patients vaccinated, encouraging them to have the flu jab through their GPs and also our staff. And we don't know yet whether the 50 is a scientifically based age, or whether it may also walk down to 40s and then 30s. So we also need to think about our workforce, particularly in our bedded services, because what we don't want is to find ourselves in a position we were in last year, as Suzanne has just highlighted, where some staff were feeling rather nervous about going in if there were cases of COVID. So there are some unknowns, but at least there is a roadmap being set out by the government. And this isn't to say it's all going to be easy, but this is just to paint a picture of what's likely to come upon us over the next 6 months or so.
Thank you, Iffy. Matthew, please.
Yeah, and I mean, I don't want to try to sound as though I'm minimising how tired people are, but and some people are pretty worn out and are hoping that the restrictions get lifted so they can get a decent holiday this year after all the rubbish holidays I think we've all had over the last sort of 15, 16 months or so, where, you say to people, have you been anywhere nice? And they say, I stayed at home again. But the only difference was I wasn't on Teams this time, So I think if people can be supported to get a bit of a break and get to see their families, that'll help. But I do want to say there's also some staff who are in a really good frame of mind. And they're reflecting on some fantastic work they've done over the last 15 months or so. Some real innovation, some real change. I mean, the MSc and I were at the Braxton Centre yesterday. We visited Danson Ward and the Birchwood Clinic. And the staff we talked to there were in, I'd say, the MSc, they were in great spirits. The Birchwood staff who'd been in there right throughout. We'd seen quite a lot of the staff and patients there affected by COVID. But they said, their main worry at one point had been they hadn't had enough admissions. They didn't have enough staff. They were really keen to be supporting people to get discharged and get out into the community and do the work they loved doing. And they were saying one of our biggest challenges was because the system had slowed down, we weren't getting as many patients coming through as we like to. And it was, so I suppose it's something that, because we are a trust that does lots of different things in lots of different places. And people will have had a huge range of experiences. So, generally, yeah, people are tired. We're all a bit tired, but there's also lots to be really, really proud of. And some staff who I think have got a lot of fire in their bellies at the minute when you talk to them about what lies ahead.
Yeah, that's a really good point, Matthew. And I think it reflects some of the teams I've seen. There's lots and lots of energy out there. And despite the fact of working so hard throughout all of this. Are there any other questions for Matthew before we move on to Ian? If not, Ian, please.
Yeah, thanks, Andy. So quite a lot I wanted to cover today. I will come back to COVID in a moment, but I just wanted to spend a bit of time on some of the exception reporting from the IBR, and then just flag up 2 or 3 things from the operational report, if that's okay. So just picking up on the conversation about COVID, I thought it might be helpful just to kind of give you some the latest detail about how COVID is impacting on our patient group, but also our staff group. So in terms of our inpatients, we continue to have 0 cases of COVID-19, and that's really been the case for about a month now, perhaps more. In prisons, the numbers are quite minimal. As of yesterday, we have got a case in Belmarsh and a case in Thamesmead, with 2 further suspected, but our Kent prisons and Wandsworth remain clear. And amongst the staffing group, again, as of yesterday, we have 3 members of staff who have tested positive for COVID-19. And just to give you a bit of additional detail, because this might be a question you have in your minds, all 3 of those members of staff have been vaccinated. And that is something that's coming up from the borough-based boards, actually, is the number of people who are actually asymptomatically COVID positive when they go to have their vaccine. So that's something that we're keeping an eye on, but I'm not sure the numbers are cause to draw much in terms of conclusions. And in total, we have 28 staff absent with COVID-related kind of issues, and everybody will be aware, particularly if you're a parent, that there's quite a lot going on in terms of children being sent home from school, and then the impact that might have in terms of people having to isolate at home. But just to pick up on Suzanne's point, I mean, the ICC, the way that we manage our response to COVID continues. We are having discussions around the kind of ongoing need for that, and I think there are clear areas where we need to continue to have that central focus, and those are around vaccination, testing, and also PPE. I think the PPE operation is run very smoothly and continues to work really well. In terms of testing, I think there's a conversation that we're having around whether we move to a kind of national testing regime, or whether we continue to kind of manage that ourselves. And I think we're probably erring on the latter, because it gives us much better kind of grip on in terms of making sure that people are being tested. And vaccination, as Iffy and others have said, will be something that we just have to operationalise in the way that we do flu. So I think we're focused in on it, and I think Matthew's point about holidays, it sounds trite, but I don't think it is actually. And from the ICC perspective, it's actually been something that we've had to really think about how we approach this tonally, because colleagues have started to take holidays abroad, and they have found that their destinations, the colour spectrum of their destinations is changing, and that means that when they return, they have to isolate. So I think we've kind of got our messaging right in terms of trying to support people to take holidays, but also helping to understand that they have responsibilities in terms of what the implications may be on their ability to work when they come back, and how we support them with that. So that's all I was going to say about COVID. Just talking through the IBR, I think I've reported at previous boards that for the last 6 months or so, there have been a number of indicators that have got stuck, frankly. So we've taken a slightly different approach with those, and I'm working very closely with the service director, and I'm reporting those back through PQAC. But there is a sense that with some of them, we are now starting to see improvement. So I'm just going to highlight some of those for the board. The first one I wanted to mention was around our 72-hour follow-up for those who have self-harmed. I mean, I think I probably said before that this is a really important indicator, and it's born out of good kind of clinical kind of practice. I'm pleased to say that we're starting to see an improving trajectory around this, with both Greenwich and Bromley hitting the 100% in May, and Bexley just under at 95%. I've done a lot of work with the directorates around reviewing our process for follow-up, and I think we feel that it doesn't need an overhaul, but we do need to tighten up the section around responsibilities around where the follow-up hasn't happened within the 72-hour period, and also working out a system of assurance, so that we know that when people haven't been followed up within 72 hours, we do know that they have eventually been followed up and risks mitigated. So I think there's some good practice already in existence with some of the borough directorates, and we're just now putting that in place for all directorates, and working out how the exec has oversight of that. Colleagues that have been around for a while will remember that we used to have something similar for 48-hour follow-ups many years ago. In terms of prisons, I just wanted to kind of touch on the indicator, which is around setting up care plans within 2 weeks following assessment. This is currently at 67%, so it's getting better. It is one of those indicators that has been impacted by COVID restrictions within the prison estates, but there is an improvement plan in place, and Lawrence and his senior management team are working very closely with Vicky and quality assurance. So I feel confident that that will get back to where it needs to be. Intermediate care has been shown as flagging as an exception now for some time. And this is around under occupancy rather than over occupancy. Some of this has been impacted by the fact that we have actually opened up extra beds during the pandemic, and we're just going through a process at the moment of closing some of those off at Eltham, and we're just in the process of communicating that out to staff. But of course, occupancy of intermediate care is something we're very excited on as part of our Home First initiatives, and our overall aim, as set out in the Home First strategy, is to actually be less reliant on intermediate care and grow our community offer. So I think context is really important with this indicator. Complaints, our response to complaints continues to be an issue. And that has meant that myself and Neil, together with colleagues from the complaints team, have met to really think about an overhaul of the way that we approach our response to complaints, and thinking about revisiting that conversation around, can we resolve a number of these complaints immediately without the need for it to go through a lengthy process. But of course, when people do make a formal complaint, making sure that we respond in a reasonable way. So we've had a good conversation around this. Neil has drafted a paper which myself and other colleagues have inputted into, and that is due to go to an exec meeting shortly, and will then come back through PQAC as a proposal for ratification. Just quickly moving on, CPA, again, another one that has been impacted, I think, by COVID recently. It remains an issue, and this is around 6-month CPA reviews. 12-month CPA reviews are not an issue. So there is a sense that this is improving. We're just off target in all directorates, and myself and Iffy have discussed adding a question to the regular monthly audits, which picks up on the timeliness of these reviews. So I think this, combined with really pushing the use of iFox dashboards with team managers, will really make sure that we see an improvement around this. And then the last thing I was going to say, which I think is picked up in detail with some of the directorates in the operational report, is our referral to treatment times. Again, this has been something that has been impacted by COVID, and I think Matthew has talked broadly around that. All of the directorates have got recovery plans in place, and in this month's operational review, you've again got some indication of the work that is happening, but clearly this is also something that we are now looking at strategically with the zero delays work. But overall, in terms of AHPs, allied health professionals, this continues to be subject to variation, but overall it is improving. It is improving, and now it's an issue around sustainability. For psychological therapies, the improvement is slower and is still subject to variation, but it is starting to go in the right direction. So that was the exception report. Before I go on to just drawing out some details from the operational report, happy to take any questions. Suzanne.
No, it's not a question actually, and it's a comment. I was really pleased to see the data on the 72-hour follow-up, and you know, it's a tricky thing to do, but I'm hoping that we'll be able to sustain that because there's clearly been an improvement.
Thank you. Steve.
Thanks. It was just a question about the intermediate care and home first strategy. It's clear. I mean, what people want is they don't want that intermediate stage. They want to, if they're ill enough, they're in hospital, and if they're not ill enough, they go home. In most cases. But that depends on us recruiting staff to work in the community teams, which are already really pushed. So how confident are we that we'll be able to deliver that strategy, given there are money restraints, but the real restraint seems to me to be our ability to recruit experienced people. How do we think we'll be able to do that?
Yeah, so in terms of governance around Home First, Steve, I think you're probably aware of this, that we've got underneath the system group that Robert and I are involved in, which is the Resplendent group, there are Home First boards now for each borough in Greenwich and Bromley, which brings together different parts of the system. What we asked those boards to do quite recently is to do an evaluation of how Home First has been going over the last few months, and just to look at that kind of discharge profile and some of the challenges, but also some of the positives that have come out of routing people directly home rather than intermediate care. So I think one of the challenges that's come up, which I think kind of links in with what you're saying, is that clearly the complexity, we're asking more from the community in terms of dealing with complexity of presentation and greater sense of acuity. And the biggest single factor around that is availability of therapists. So that was kind of drawn out as an issue. So you're right, money is one thing, recruitment is another. There are some indications of success, but also I think it's driving a different kind of conversation, particularly with colleagues at LGT actually, around what happens prior to discharge, what happens after discharge, and is there something we can do differently with that collective resource that is already there in terms of particularly around therapists. So I think it's something that we continue to explore. I think district nursing, that I know continues to be a cause for concern. In terms of our kind of financial settlement overall for community health, it's not quite where we wanted it to be. And we are looking at how we use the money that we are getting and how we apportion that. And it's really difficult because, as the directorate reports show, we've got a number of services where we've got waits and we want to do something about that. And then you've got services like district nursing which don't have waits. They can't have waits, they just have demand and they have to absorb it. So we're just working out the kind of how we apportion kind of resources around that. And for me, it's really about drawing in the different other parts of the system into this, local authorities and the acutes as well, just to see if there is something in terms of a whole service offer, GPs as well, to try and kind of move that demand a bit. So I think it's a combination of using the money that we've got. I think there's an indication we can recruit, but it's still tricky. And that kind of system readjustment so that we try and flow some of the work to different places. But that's, you know, hopefully that helps. Sorry, Andy, I'm sort of taking over. I don't know who was next, but I'm going to go to Steve and then Asma.
Thanks, Ian, and thanks for a very comprehensive report. I know you're coming on to the operational dashboard. Particular thanks for the comments on the hydrotherapy, because certainly from a infrastructure perspective, as we said before, that has an impact on the Goldie Lee development. So it's good to know, you know, what's happening there. And thanks also about the 30-day response to complaints, because certainly that was a question I was going to ask. I do think when you come to reflect on that with Ian, you know, is the target correct? Is our process correct? There's a number of different angles on that. But for, as you touched on, for a continuing problem, it's not really acceptable where we are. Just going back to the comprehensive report and thinking back years ago to the mid-staff situation, I just wonder if we're getting too much information in the report. No, I haven't spoken to any of the other NEDs about this, so maybe you might want to talk to the others outside of the meeting. But you know, we're not seeing the wood for the trees kind of danger. I just feel that we're right on that point. But it's good that you're going to talk us through some of the main you know, points for us to know. Two questions from me. You were just talking there about recruitment. And page 49, you touch on the ASD recruitment, one unsuccessful campaign followed by a successful campaign. So I'd just be interested in your thoughts of why was one more successful than the other, as there is a theme to that. And then secondly, probably more important, page 55, where on the inpatients mental health services, I know it's a snapshot analysis of were the patients in the right place at that particular time the analysis was taken. But nevertheless, when the analysis is showing nearly 50% are in the wrong place, admittedly, we know the calls, 36%, I think it was, were due to delayed discharge. But I think for us as a board, that's not a good, and for you, I'm sure, the executive, that's not a good situation, is it? If we just take it on that one-off analysis, nearly 50% of our patients are in the wrong place. That's the basic finding. So I'd be really interested in your thoughts on that. Do you think that's exceptional? What can we do about it? Because I don't think we should be living with that kind of scenario. That's it from me.
Okay, thanks, Steve. I'll try and remember all of those different points. So remind me if I don't. So I think in terms of the kind of the first point, which I think was around how much detail is in the operational reports, I think it's a good challenge, and it's probably something that I mean I certainly welcome a discussion with you as non-execs about how we kind of continue to monitor that. I think in the past there's probably been too little in the way of detail. I think, if I'm honest, I'm having to manage the enthusiasm of the directorates for providing you with as much detail as possible. And I think I've particularly asked them to highlight challenges and risks around weight, and that's been a kind of major flavour, I think, of all the directorate reports, but also to show the kind of progress that is made. So I think, from my point of view, it's just to kind of give you concrete examples from each directorate about some of the things that they're working with. Yeah, we can perhaps that's a conversation for a strategic board, really, about how we kind of finesse that more, and also how it fits in with some of the strategic work which encompasses this and the transformational stuff as well. In terms of that particular recruitment around ASD, I would have to go away and find out for you, Steve, why one campaign was unsuccessful and another was successful. I mean, when we've had this situation before, it's just simply a case of timing and just who is around at that time. But I'll certainly work with Lorraine to see if there's any lessons to be learnt around that. In terms of the mental health kind of inpatient occupancy, which I think was the last point you raised, I mean, this is a preoccupation of mine and the wider system at the moment. So in terms of Oxleas, we've got pretty tight centralised processes now around who comes into hospital. But of course, and that's helpful in terms of managing weights, particularly as it manifests itself in ED. But in a sense, that probably is taking a disproportionate amount of our collective management time, because of the point that people are waiting for a hospital. Although we can kind of manage their presentations in different ways, really it's probably too late. So the focus at the moment is very much on that back end and who is in hospital, and are there people who don't need to be there, and could they be managed elsewhere. It varies from borough to borough. It manifests itself more in Greenwich and Bromley rather than Bexley. There are all sorts of variables at play with this, including people's status under the Mental Health Act. What we're doing at the moment is running a series of what's called mini MAID events, looking at long stayers. So Helen, myself and colleagues ran one in Greenwich yesterday, which I have to say was excellent in terms of clinical involvement and kind of organisation. And what that showed actually was that of the people that have been staying there 90 days, 5 of them on each ward, most of that was because of the complexity of the clinical situation. And when we came to it, it wasn't necessarily that they weren't in the right place, it's just that there wasn't a clinical place for them, an alternative. I mean, people were treatment resistant. So the issues around kind of social care delays, etc., wasn't as apparent as I expected. But that's not to say that they aren't there. And certainly as an ICS, we are flagging this, myself and a colleague at SLAM. And over the next few weeks, we are running synchronous MAID events in each borough in South East London with a fairly kind of senior involvement from local authorities and other bits of the system to try and kind of move this along. And from my point of view, it's about having that kind of focus on the fact that we have got delays in the same way that acute hospitals have delays, but there's not the same system visibility. So absolutely trying to get into that kind of back end and also tackle day-to-day practice, which is about community involvement, estimated discharge for all patients, red to green, etc. So I can assure you that this is the bit that we are now focusing most on at the moment. I've got Azra and then Joe and then Suzanne.
Hi, mine's on page 38 of the pack. It's about the digital inclusion update that was done. So there was a lot of issue around the timing of being able to say whether or not we thought that particular pilot was working. And I'm very interested in knowing what the time frame is, we think, for when we'll be able to come back positively and whether or not we think that was successful or not, particularly in relation to possibly doing further rollouts across other services other than ALD.
Thanks, Azra. I mean, it's very early days with that project, so I think I would have thought that we need to give it at least 6 months before we can kind of really on that. I mean, I'm conscious I haven't gone through the operational report as yet. I was just concentrating on the IBR, so this was one of the areas I did want to highlight as a positive, actually, because I think the comments from service users could kind of give a very kind of nice level of detail about the impact it has on individuals. But I think it is indicative of how some of our kind of more marginalised kind of groups of service users can be empowered through the use of digital. But I guess the timing point, Azra, is the amount of support that individual service users need to kind of engage with it and basically take on something that they had never done perhaps in the past. And I think that's the bit that's going to take a bit longer. I think ALD are really, I think they're kind of showing real innovation in terms of bringing in other people to support with that. But I would really say that this is a kind of blueprint for further work across other groups. Yeah. I don't know if that's answered.
I think it's just a little bit in terms of time frame, and as I said, I am really interested in seeing how we would be able to take it across other cohorts of our patients and clients who may be more used to technology, and therefore the rollout could be quicker.
Yeah, indeed. Joe?
Thanks, Ian. Mine is just to follow up on your answers to Steve about district nurse pressures. And I'm just thinking about all the elective catch-up that's going on with the acutes, whether we've assessed what the impact might be on our district nursing teams. And if we think that's material, and I'm sure Azra will say the answer is no on this, but is there any chance that we could get a slice of the elective monies the acutes are getting?
Azra might want to comment on that. My sense is probably not. In terms of kind of monitoring the kind of connection between the two, Joe, I mean, that's where that resplendent group really comes in, because we have good operational representation from LGT, but also from DVH and the PRU. And it does enable us to kind of get a sense of what their planning is and what their trajectories are, and then to try and kind of adapt to that. So I think the processes are there, but it doesn't mean that we've got the resources to be able to do it, which is the money question. So yeah. I think the relationships are working well, structures in terms of process and pathway work is working well. It's just whether the kind of volumes of referrals are going to be such that it's going to be tricky to do that. I mean, another dimension to that with district nursing is around general practice. And I think there was perhaps a sense a little while ago that general practice, the kind of flows to them had somehow been kind of managed differently, so they weren't experiencing the same pressures. But I think the narrative that I'm getting back, and Matthew might want to comment on this, is that general practice are really actually kind of working really, really kind of hard. So it's a pressure that's being experienced everywhere, I think.
Yeah, so just to come in on the point that you were saying around the funding, we are not able to access it because it was one of the questions we directly asked. We said if we were able to help with the overarching pathway, would we be able to get some of that very substantial support that's there for the elective recovery fund? And we were told very categorically no. So I think there is something that we need to probably address with the ICS as a whole around some of the community physical health, because I think we've seen now across a range of different strategies that are coming out that acute care is very, very high up on the agenda and the recovery elements. Mental health definitely gets a look in, but the area that I think is missing from quite a lot of those strands is the community physical.
Thanks, Ezra. And Suzanne.
Thanks, Ian. I wanted to pick up a point about the recent serious incidents in prisons, and it may be you've had a long session with us, and it might be something as it comes up again under the mortality review, we might want to pick it up there. But this was on page 52 of your report, where you refer to the recent deaths in custody, and as Nedsby had been alerted to that by Matthew. I wanted to seek assurance at some point during the board meeting that we are approaching these deaths in custody and the prevention of deaths in custody with the kind of same degree of assiduousness as we would do, for example, in our inpatient wards. And it's around, for example, the way in which we now have a system, and partly prompted by the work in adult mental health, of doing an immediate alert where there is any quick learning to come out of deaths to our other services, as well as looking at the kind of longer term. But I don't know if you would care to comment at this point on whether there are any significant differences in the way in which we respond, or indeed significant similarities. There's not a lot of detail in the report itself, but as I say, it may be that we would want to sort of park this conversation and come back to it when we talk about the mortality review.
Thanks, Suzanne. And it may be the way that I've badly structured this part of the agenda, but I was fully intending to cover the deaths in custody. So I'm very happy to do that now. If there aren't any other questions around the IBR. In terms of the operational report, I think colleagues have asked questions around most of the areas I wanted to highlight. The only additional one I wanted to highlight positively was the work that's been going on in Greenwich, supported by Abby, around our community mental health teams, because this has been an area of concern, I think, expressed at the board previously, but you'll have seen in that report that caseloads are starting to come down. We've been really successful in terms of recruitment, and I think there's a real sense that things are moving in the right direction. So I just wanted to kind of make sure that you that was landed with you. But Wandsworth and deaths in custody at Wandsworth was something I did want to highlight, and if it's okay, Andy, I'll go through this in some detail about kind of what we know about what's happening, but also more importantly, what we're trying to do about it. Just to reiterate that since the 1st of December last year, we've now had 8 deaths in custody at HMP Wandsworth. 7 of those have been by suspension through hanging, and 1 has been an overdose. Just to kind of remind colleagues, I'm sure you're aware of this, about some of the context of HMP Wandsworth. It is the largest prison in Europe, 1,600 prisoners. In terms of our presence in the prison, we directly provide the primary care offer, and then we subcontract the mental health and substance misuse services to our colleagues at SLAM. And that has been the situation since September 2019. I think, so clearly this is a high number of deaths in custody. This is a real cause of concern for myself and the exec, but also obviously for the governor at Wandsworth and also NHS England. So in terms of the actual review of what is happening, I just wanted to let the board know that in agreement with Jane and with Andy, we are treating the most recent deaths in custody as a board level inquiry. So the latest two deaths are going to be incorporated into the existing review that is about to start next week, because I think it seems sensible to try and incorporate the three together. I'm very pleased that both Joe and Sue are going to be on the panel with me, and I will be jointly chairing this with my counterpart James Lowell from SLAM. We also have an independent member on the panel as well. We're treating these deaths in custody as kind of serious incidents from our point of view. But in the meantime, there is something about making sure and providing you as a board, but also the governor at Wandsworth, with assurance that we are taking immediate action in terms of trying to make sure that what is on offer there is safe. Lawrence Mack, the director, has been very involved with both the governor and with SLAM. He has now got a regular, re-established, I think, relationship with SLAM at director level. If I can be frank, I think that the line of sight from SLAM to their services in Wandsworth perhaps hasn't been as visible as I would have imagined. So I think Lawrence meeting with his counterpart from SLAM is on a regular basis is a way of ensuring that there is kind of senior level scrutiny from both organisations. Himi, who is the manager there, has drafted an action plan, which I have now seen, and we're just ratifying this with the governor, and I would like this to go back through our own internal governance process and think about how we monitor the improvement plan from a kind of board perspective. My view is that this is probably something that needs to be on the agenda for PQAC, and I've certainly had that initial discussion with Andy around that. But just to give you a sense of some of the issues that we are flagging as part of drafting that action plan, there are concerns about the mental health offer at the prison. When we were mobilising the contract, the eventual financial settlement for the mental health element was reduced, and that was raised as an issue by SLAM at the time in terms of their ability to deliver the model. However, the middle of last year, we concluded a conversation with them which saw more money being put into the mental health contract, which brought it back to the level that it was initially envisaged to be at. So as far as we are concerned, they are in a position financially to deliver the specifications of the contract that we need them to. Having said that, putting aside the money, there remain some concerns that we are talking to SLAM about that offer, and I'm very happy to detail them. Broadly speaking, we think that there are issues with the stepped care model that they operate, And what that means is that there's a weakness, we feel, in provision for those with prisoners with depression and low-level mental health issues. There is, I think, a concern around their published acceptance criteria for mental health services, which can result in an inconsistent offer. And relating to the first point, we have got concerns around a lack of assurance around the kind of clinical effectiveness of the offer, particularly, again, for those with depression and low-level mental health issues. And the reason I emphasise that is because of the deaths in custody. A number of those prisoners who have died did have pre-existing mental diagnosis of mental illness, but if not all of them did, all of them had some vulnerabilities and were displaying kind of issues around mood. And I think so. There's a kind of sense here about whether we're picking up on the kind of broader needs of the prison population in terms of kind of lower level mental health issues, which can then be exacerbated by being in prison. So just to build on that, I think there's been a reduction in the offer around those who self-harm and those who are considered a suicidal risk. And this really speaks to the heart of the issue, which is that we have asked SLAM right from the beginning, as part of the mobilisation conversation, which I chaired, that we wanted them to implement the health and wellbeing offer at Wandsworth, which is the offer that we have in place in the prisons where we deliver mental health services. And there is a question as to the extent they've been able to do that. We have been raising these issues consistently with local management in SLAM, and I think there is a view that the response hasn't been what it could have been, hence why we've now escalated it to director level, and I have now escalated it to Q level. So in summary, I think there's an issue about the model not being operationalised as we want it to. This is not providing for a kind of a wide offer for those experiencing low levels of mental ill health and suicidality. The money issue has been resolved, and we now need to see SLAM implement what we want them to do, and the action plan which Himi is drafting will be our way of ensuring that that happens, and it's done in a timely way. And as I say, there's something about the kind of governance around that, so that we're cited on it. What I think the only outstanding thing I would say is that if we don't see an improvement within a reasonable time period, are there any kind of contractual levers that we can pull to kind of do something different? But just to kind of reiterate, if I haven't already, this is a huge concern. It's absolutely tragic that we've had this number of, well, any death in custody is a tragedy, but this number, it's completely exceptional. We need to do something about that. We need to provide the board. I need to provide the board with reassurance, but also I need to provide the governor at HMP Wandsworth and NHSE with confidence. Just to say that the governor and NHSE are supportive of the approach that that I'm outlining, and they're supportive of the kind of draft action plan. So I'll leave it there, and very happy to take questions. Steve?
Yeah, thanks, Ian. And as you rightly say, it's a tragic situation. Just for clarity, I'm assuming that the health and wellbeing programme, but correct me if I'm wrong, is based on the emotional wellbeing programme that we had at Swellside. Yeah, and I remember that reduced suicide thoughts by 66%. So it was an enormously successful program. So did I take what you were saying correctly, that they don't have anything like that in operation at Wandsworth? Is that basically the situation?
They do, but it's the extent to which it's been operationalised. So we made it very clear, Steve, that is what we wanted. And Sunita, who has been instrumental, she's a service manager within our prison services, but she's been instrumental in delivering that model within our other prisons. She worked very closely with SLAM as part of the mobilisation to make sure that that was up and running. For whatever reason, it hasn't been operationalised to the extent that we want it to. So the reach of it and the coverage of it has not been there. As I say, money was raised as an issue early on. We've resolved that. There's been issues around recruitment, which we're kind of focusing on. But I think fundamentally, it's the extent to which colleagues at SLAM have prioritised this alongside their specialist mental health work that they do within the inpatient setting and within a kind of higher level kind of clinical setting. So this is about them implementing what we need them to do.
And do you think that needs, just as a follow-up, do you think that needs to be raised at a higher level? I mean, chair to chair. I only ask because the emotional wellbeing program was such and the derivatives from it are such an obvious success, aren't they? And it sort of jumps out at you that, well, I'm sure lives would have been saved if we'd have had that from.
And if you boil down what's in the action plan to resolve the situation, Steve, that's essentially it. It's delivery of that and delivery of that model quickly as possible.
Okay.
So, although there are different elements which contribute to that, that is fundamentally what we feel will make a difference in terms of reducing the this happening to the scale that it has over the last 6 months.
But do you feel there's any need for pressure from the top to make that happen?
My sense is that my counterpart at SLAM is taking this seriously. I think the fact that we're jointly chairing the reviews is helpful. What I would suggest is that I continue that conversation with him, and I will certainly obviously raise this with Matthew if I think it needs to be kind of raised any further. I mean, there's probably a conversation, Matthew, with David as a kind of chief exec, but I'll kind of take your thoughts on it, Matthew, or your direction about what you think.
Yeah, I think we are in other places a subcontractor. This is the way these relationships have to go. And we manage it now also within the SLP around forensics and other areas. And there's been occasions where it's been the shoe's been on the other foot, and we've been the provider that's had to raise their game. I mean, we have contractual relationships there, senior operational relationships there, and I think we need to respect the integrity of those relationships, while also recognising that SLAM are an important partner of ours as well. We shouldn't though treat them differently for the purposes of making sure that the men in the prison get the right quality of service and the right access to the service. So I think for Ian and his counterparts to work through the improvement trajectory in the same way we would expect any provider who's contracted with us, I think it's important to do that. I know Lawrence has been very actively involved in discussions with NHSE on the commissioning side, and also with SLAM on this too. Prison healthcare is difficult. Lots of what you do is constrained by the environment in which you're working. If this was happening on an inpatient ward, you could flood it with staff and make sure you put extra resources in here. We're constrained by the number of prison officers available to support us in some cases to interact with the men as well. So there's broader difficult issues around here. My preference is Ian coup to coup, Lawrence and his peers to deal with this contractually, and for us to escalate as and when necessary. As a courtesy, we'll certainly let David and colleagues know, but I think let's leave it to the people managing the ops contract to manage the ops contract in the most appropriate manner. And we have to be very clear that there's no perception of favoritism or others. because it's SLAM with whom we do a lot of great work as well, and I would expect them to treat us in the same way if we were failing to deliver on a contract we had with them.
Thanks, Matthew. Suzanne?
It's partly a comment followed by a question. So I'll value seeing the action plan when it comes to PQAC. I was wondering, I mean, there was a really good systematic review that was published earlier this year on risk factors for suicide in prison, and the Samaritans published a report at the end of 2019 that, probably because of the circumstances, didn't get as much attention as it might have done at other times. And I'm just wondering whether you know if the way in which we are kind of working with potential suicidality in prisons reflects the most recent research.
I'm fairly confident it does, Suzanne. I mean, what we want to emphasise is is that kind of work in the context of working with prison staff. So the ACT process. Yes, I think it does. But I will certainly kind of raise that with colleagues within the directorate.
Thank you.
Thank you, Ian. There's a very good discussion, quite rightly, we had this in part one. It's a matter of record of our concern over this. I was thinking about the action plan, which is going to PQAC, but would this be something that'd be helpful to send to NEDS anyway, Ian, at this time, so that we can all see what the action plan is? I totally hear what you say about, and Matthew, about let them get on with it. But the offer is there from myself, or I'm sure from you, Matthew, to intervene as appropriate. And we clearly can't let the situation deteriorate in any way, because this is obviously incredibly important. So the offer is there to assist if we can, without getting in the way of what you're currently doing. I suppose what we're looking for is that assurance that everything is being done that ought to be done at this stage. And as you say, Ian, there isn't any hesitancy to deal with our subcontractor in this case, obviously, as SLAM. Matthew.
Yeah, I mean, I was fortunate. Emissy and I spent time with Lawrence yesterday at the Bracton, and I did talk to Lawrence about this. And I mean, we are good at we're a good provider of prison healthcare. We do it well in physical and mental health. I was really struck talking to the governor at Swales side a week or two ago by how impressed he is with what we can do. Equally, though, I know that we have hard times in our services as well, and these can be difficult and tough areas to recruit to from time to time as well. And I think there is, I'm absolutely with you that, if we do need to speak to people to say this needs to be on your agenda and they're right on. I think Ian and James, the crew at SLAM, have got a good positive relationship. And I think in all of our dealings with James, we've found him to be tremendously transparent about, what's happening within their operations. He's very clear as well in terms of his values and where his drive is to improve services. And, what I've not picked up yet is any resistance at that senior level within SLAM to recognise that this is an issue that needs to be dealt with. I think that the more difficult technical bit is the ongoing relationship on the ground, because SLAM have seen a change in provider to us quite recently. We do things differently. We expect it to be done differently. And I think, as you say, it's us giving the right air cover, but also recognising the technical expertise of our forensics and prisons teams, who will have to work with their clinical peers and colleagues in SLAM to make sure that we get the model right. Because there's not an easy option to say, why don't we do it ourselves? We'd have to recruit, we'd have to find people to put in. It's not an easy area to recruit to. As always with these cases, and we've been on the other end of this from time to time, all of us at some point in our careers, I'm sure, your best option is always to improve the current offer and to get the current offer back to where it needs to be, because that offers that consistency in staff. It avoids the massive disruption you get if you try to go for different models. So I think let's give Lawrence and the team the air cover, the support and the backing we need. let's Ian work through that really good relationship he's got with James and that real transparency around our concern for quality and safety. But as you said, 8's a lot of deaths, you know, it's not what we want to see. And if the numbers keep ticking up, then we won't hesitate to use the right range of measures to address it, because and none of us, and neither David Bradley nor his executive team, would want us to see these deaths to continue to happen, because it's you know, it's a pretty shocking set of circumstances for us to be coping with within the prison.
Thank you, Matthew. Ian.
Yeah, just a kind of an additional point, I suppose, which hopefully kind of gives evidence that apologies for the marking. Gives evidence that SLAM are taking this seriously. I think the manager at Wandsworth has other responsibilities which have now been taken off of her, so she can focus solely on Wandsworth. I think getting the director, Hilary, involved is really helpful. And I will continue to talk to James about whether she has the capacity to give this sufficient focus, because she's got a busy job. She looks after Croydon as a borough and forensic services, and Wandsworth as a bit of that. But I think the real kind of, so that kind of focus on Lawrence with his counterpart, Himi with the manager from SLAM on the ground is really, really important. And I think the direction that's been given to Himi is to, you know, kind of adapt the tone as circumstances need, and assert his right to kind of, in terms of managing this contract, to ask searching questions of colleagues. And I think James is very up for that, and is putting that message down through his management team. So I think relationship-wise, we've got it right. We just now need to deliver on the specifics of the plan.
Well, thank you, Ian. I was just thinking about timings, given we don't have another board meeting, do we, until beginning of September. It will be I know that I have the meetings on a Tuesday morning, but of course NED colleagues aren't party to those. I would have thought, as a matter of assurance, I'm just thinking about how we should keep colleagues apprised of any further developments, and it might be something that we do. Matthew, do our NED updates, and we need to check the diary to make sure if they're in on the NED updates, or we do a one-off or more through July and August, because we can't let this summer period, lose focus. I know you won't lose focus, but as far as the NEDs are concerned, NED colleagues, is that okay? Do you agree? Is that as an approach? It will go through PQAC, but we get updates, and we'll fix some times to get updates as we go through the summer, because, as I say, we can't wait for 2 months to discuss this one again, if that's okay. Thank you ever so much, Ian. I mean, a really comprehensive report. You've really, I think, really reassured us about the grip that you and colleagues have got on this, and those relationships, and very, very difficult, very tragic issues. And we'll look forward to further discussions in due course. Is there anything else you want to raise with us, Ian?
No, thanks very much, Andy.
Well, thanks for a very comprehensive all-round report. Just on the point that Stephen raised earlier about the overload of information, I haven't discussed it with colleagues yet, and I will, by whichever format we're going to go. But I've asked Steve James to do a review of the way that we operate. And I'm sorry to just sort of bring it in here, but it's an appropriate time to mention it, because we're just sort of crystallising how we might do that, and talk to colleagues, both for the exec and non-execs, about how we do business, how we learning from other trusts, and Steve's long experience with us at Oxleas, but also his experience with LGT and from other trusts. The learning points from our internal well-led review. And then one of the points is looking at data and how we can be using them in a more timely and less resource-intensive way. So I've just been discussing with him, really, as his parting present to us, is really how do we do business? How can we refine that? How we can save time and yet really focus very much on the important matters that we've got to deal with, and say to absolutely capitalise on his huge wealth of knowledge, and to capture his observations before he goes. Steve and Sally, if you're happy, we'll circulate what we've discussed so far to NED colleagues and exec, just for any immediate thoughts. But I'm quite keen that Steve cracks on and swiftly and comes back to us in after the summer with some findings about how we might improve the way that we do business as well. Is that okay, everyone, on that? All right, okay, that's really, really good discussions. I'd like to take 10 minutes if you don't mind. So can we do 12:10? We'll resume at 12:10 if that's okay. Thank you. Welcome back, everyone. Before we start the next item, Iffy, I just realised that I didn't invite you in. I'd forgotten about your hand. Did you want to add anything to our previous discussion?
Oh, not really. All I wanted to say, and I have already communicated it, is that Matthew should please talk to David and ensure that their board at SLAM are cited and are also discussing this, because I think they'll be quite interested to know what's happening to people under their care. So,
yeah, no, thank you. Apologies for missing out on that. I was reprimanded during the break for missing you on that one. I think you're absolutely right. We are very keen to have this in part one on the record, and SLAM should too. We do need a record of this. We know that when CQC do come calling, they want to see what we've discussed, and often the answer is, if it's not on the record, it didn't happen, as far as they're concerned. Matthew?
Yeah, I mean, Ian and Iffy and I have been in contact during the break there. And Ian is going to speak to James, his opposite number at SLAM, just to let him know we've had this discussion, so that James has then got the opportunity to inform David Bradley, and I'll then follow Bradley. And I think David should hear it from his coup, rather than get cold cocked by us. He may already be aware as well, but we'll follow that up in rapid order and make sure that they're fully cited, that it's reached this level of concern within Oxleas. Certainly, they may already, as I say, be on top of it. We'll do so.
Yeah, well, no, thank you. Thanks, Iffy. Right, we'll move on to the next item, item 7, Oxleas strategy. Who's taking us forward on this one?
Abby.
So am I starting then, Rachel? Is that okay?
Yes, please, Abby, go for it. Thanks.
Okay. Thank you very much, Sally, for sharing my slides. What had been agreed when the strategy was launched in April, it was that we would give regular updates to the board. So I'm just going to talk you through the updates on the Great Out of Hospital Care using slides. So next slide, please, Sally. So this is just what I'm going to be going through, and I've only got a few slides, and then I will take any comments and questions at the end. Next slide, please. So just to provide a bit of context, when I was looking through these slides yesterday, I realized that we had started this process towards the middle of 2019, which is about 2 years ago now. And as part of the consultation and engagement process, we spoke to our system partners, quite a number of staff and service users and members of the public, which then led to the priorities that are stated in that slide, with priority 2 being Great Out of Hospital Care, which I am leading on. And when we launched the strategy in April of this year, one of the aims of this particular priority is to ensure that people that live within our footprint, which is Bromley, Bexley and Greenwich, and I've included beyond because we've got prison services in Kent, and maybe we will have prison services beyond that. So that's why the beyond is there. And we want to give them the tools and skills which enables them to manage their conditions, whatever these may be, in their own communities or in the most appropriate place. Next slide, please. So we've heard some of the things that are on this slide, and I'm sorry it's a bit of a busy slide, but it's just the best way to present the case for change. So as our strapline says in Oxleas, we're here to improve lives, and I'm very committed to that. So one of the first things that we're aiming to do is improve the outcomes for the people that use our service. When we were carrying out the engagement exercise, apart from waiting times, the most thing that people came up with as service users was the fact that they wanted care near home or in their homes. And this is backed up by evidence, both from mental health evidence and from physical health evidence, that the outcomes for service users are much better when the care is provided in their homes. It enables people to use their strengths to improve their recovery. So from my point of view, that's one of the most important things which has led us to carry out this work. We've heard in Matthew's report about the increased demand on both our physical health services and our mental health services. And in Bromley, Bexley and Greenwich, there is the projection that the population will increase by about 10% in over the next 10 years, and with the average age increasing at that time too, because people are living longer, which essentially will mean that there'll be an increased demand on our services. And the demands that we're seeing so far, it's not just the demand, it's a complexity of the demand as well. Our CMHTs at the moment, and I'm doing a piece of work in Greenwich, have the largest caseloads across London. So that's something we will have to be looking at. And we also know that there has been an issue of too many transition points in some of the way the services are structured, which means that some people that don't fit neatly into the boxes that we've got at the moment tend to fall between the caps. Apart from what we're thinking about locally, there's also been national mandates in the long-term plan as to the services we should be delivering over the next 4 to 5 years. And then we've all heard about the money earlier on in the meeting, and we can't move away from it, that there's a finite resource that we're working with. So we're going to have to be looking at the models of care that we deliver, and this is what we'll be doing within this piece of work. Next slide, please, Sally. So no transformation or change program starts from zero. So what we've done with the Great Out of Hospital Care is look at the work which is taking place in Oxleas, locally within our BBG footprint and across the system, as in the South East London system, the South London Partnership and Pan London work. And those 3 columns show what is going on under each of those headings. I won't go into them, but what I want to do and what I want to be able to do to the board is to give you progress updates on what we identify as being the priorities. But I need to know what else is going on, which may feed into what are the big priorities that we identify. So that's the work that's going on across the piece at the moment. Next slide, please. So I always get asked the question, how do we know that we're making people better, and how do you know that you're making progress, and how do you know whether a change, what you're trying to introduce has made any difference or has changed anything? So we need to have a framework to ensure that we have oversight and are able to monitor progress, so that if there are any difficulties, we should be able to support either the individual project leads or directorate management teams to unblock whatever the challenges are. When we were doing this scoping exercise, what we did find is that most of the projects that are ongoing at the moment are at the execution rather than the initiation and the planning stage. So we will be asking for updates once we've stratified in terms of priority what we will be looking at. And it will also enable us to understand whether there are any gaps or whether there are other things that we need to do in order to meet our greater goal. And when my thoughts are that when you're doing something like this, and what I found out so far is that it's going to be the sum of the total that's going to make the big transformation and change. And that's what we want to be able to look at and to be able to define. Next slide, please. So we do need to measure the outcomes of what we're trying to achieve. And so we will have outcome measures, and we're trying to define what those outcome measures are. There's some that have been nationally mandated, and there's some that we will have to consider dependent on what our local pressures are. It's important that our measures of success are not just about the data. We have to hear about the kind of qualitative feedback as well, and how it's appealing or how it's making a difference to probably individuals or group of individuals. So those are the outcome measures we're looking at so far. And I've had discussions this week with Simon and Robert, who deals with the physical health and mental health side, just so that we can start to nail down what measures that we will be looking at going forward. And when I give further updates, I will use these measures and the progress on these measures to give updates and feedback to the board. Next slide, please. So as we have done right from the beginning, we want to make sure that we are communicating each step of the way to all our stakeholders, staff and our service users. And we want to ensure that they are engaged, because this is something that we want to appeal to the hearts and minds of people across the trust, regardless of which directorates they're working in. My view and my vision is that whoever comes into the trust, whoever they ask, whichever member of staff they ask, should be able to talk about what we're doing. And that's why our communication strategy will be targeted towards that. So those top headings are what we've done so far. So we've used social media, we've used focus groups, both for staff and for service users, and we've done the good old-fashioned surveys via links, and I don't think we've used paper, but we have used SurveyMonkey and links to ask people what they think. And so we've got a short and a long version of the strategy, as well as an animation. And I've seen the animation. It took me back to my years of watching cartoons, but it is a good animation. So it's just to get people interested and focused on what we're trying to do. But we will have a much wider communication strategy, and those are some of the things that we will be doing going forward. So that's my last slide. I don't know whether people have any questions, and it was a canter through, but that was the only way I could present the amount of information I had.
Yeah, Missy?
Thanks, Andy. Thanks for that, Abby. It's great to see all the progress that we're making there. But I was just wondering, what would you say was the biggest challenge that you've come across that you weren't expecting, having started this process?
The way things are kind of interlinked, even though there's so many projects which have got so many strands of governance and things that people are doing, but they're all interlinked, but people don't know how they're interlinked. So I see my role as bringing it all together. I think that has been the biggest challenge, because I go and I hear things. I thought, well, did you know that we're doing great out of hospital care? And that links in. And I've also had people coming to me and letting me know that this could help what you're doing. So it's just the vast amount of work that's going on and trying to bring it all together.
Stephen?
Yeah, thanks, Abby. Great presentation, and the work we're doing on it is excellent. It's a tremendous strategic initiative, I think. And as you say, the outcomes are very measurable and justifiable. Just one question. I know you've got carer feedback on there. I just wonder your thoughts on for family and carer feedback, whether we need to do a bit better at communications. Because I'm just thinking that anecdotally, the service user, the patient, invariably wants to go home, don't they, usually? But how one often hears about the family thinking, oh, we're just trying to free up a hospital bed. And so I'd be interested on your thoughts of, is great out of hospital care quite so appealing to the families and the carers? And secondly, are there areas where you think we could maybe manage that a little bit better to persuade them that this is the right way to go?
The simple answer, one-word answer to that is yes. And I think the issues that family have is the support that is offered to their family member that's going back to wherever the best care is delivered. And great out of hospital care doesn't necessarily mean that you get the care in your home. It just means that you get it in the best place for you, which may not be a bedded service. If I'm looking at it from the physical health point of view, just by being in hospital, if it's a physical health and you're in bed for a week or two, you're already losing some of your functioning. But if you're in your own home and the support comes to you, you can maintain as much as possible what is your normal day-to-day activity. So I think from the family point of view, if they feel that that is what is best for their relative and you explain to them why, and they have that support and see that support. From my experience is when people don't have the support, that they become frustrated and just see it as moving the problem from one place to the other. But that's not the intention at all, is to make sure that the person has the best possible outcome.
Abby, do you want to take over the sharing of this rather than me coming in?
My computer's funny, so I can only see hands. I can't see the names.
Okay.
I can see Suzanne.
All right,
Suzanne,
okay.
you can go there.
All right, Suzanne, please.
I was happy to come in after Matthew and Ian, who both put their hand up before me. So
Okay, so Matthew, Ian, and Suzanne then.
Yeah, I suppose it was just going to reflect that actually, not all families react cheerfully to the news that we can send your loved one home earlier. And it's true in both acute physical health as well as in mental health hospitals. And I suppose if he, with his many, I think he's been on call since February now on the weekends. But one of his reflections was, particularly during this last lockdown, how many people we saw being brought to ED by family members who just said we can't cope anymore. And I suppose, there's always this kind of, we want to get people home, we want to care for them in the place where they live. But sometimes for the families and carers, actually an inpatient admissions respite. And also I know from talking to Abby that particularly in Bromley, we do have some service users and their families who kind of almost, I need to get my phrasing right here. They almost feel as though there's a right to a bed at certain times in their illness to help them as part of their recovery, and almost a sense of entitlement that we should support them with an admission as a kind of respite stay. And I suppose in a constrained environment, it's a difficult balance, really. So I think the carers' voices are really important here. We shouldn't underestimate the respite value actually of an inpatient stay there sometimes. And any of us, I think, can imagine, any of us who's been to the Erith Carers group, being a 70-year-old set of patients with a 40-year-old son, parents with a 40-year-old son who's got really acute mental illness, actually, it must be such a hard thing to live with, actually. And sometimes that week or 2 weeks when they're in our services, much as these people love their children, actually, that what it does for their home lives, it's a really complex set of dynamics here, isn't it? Abby and Ian and Effie know this stuff better than I do. So.
Ian?
Yeah, thanks, Abby. It was to really come on the same point, and I think it's a good one, Steve. I don't think it's that dynamic that you've kind of pinpointed. It's not just about families wanting people to be in hospital even. I think it's a challenge once people are being treated in the community as well, that not just families and the social network, but often the service users themselves don't always agree that our assessment of their improvement and therefore where we get there is always aligned. So people can experience it as feeling abandoned. And myself and Helen were having this conversation with colleagues at RBG and with patients and GPs this week, and it does really kind of stress the need for good engagement, which I think is what Abby's talking about. I mean, that's just a kind of fundamental thing about how we talk to the people who use our services and their network, so that we try and get an alignment around what is the best thing for that person.
Thanks, Ian. Suzanne?
Thanks. I wanted to come to the measures of success, which I know are emergent, but I'll just sort of comment on a few of those. Before I do, I'm really interested in this conversation about the need for a respite, because I think you're absolutely right. And if it's going to prevent family care from falling over, maybe we ought to be looking seriously at providing something that's not an inpatient bed, but is respite for family carers. But that is just a thought prompted by the conversation that had gone before. I know, Abby, as I say, that what you've put down here are things which are kind of emergent. But I have to say the thing that struck me about the quantitative measures is that the sorts of things that were listed are all... I'm not saying that people would be deliberately gaming the system with these, but if we think about reducing referrals into secondary care, we could do that without it indicating any kind of improvement in the sort of care that's being provided for people out of hospital. And it's the same with manageable community caseloads. I mean, we can make them manageable by just closing the list. So I thought, things like reduced complaints and reduced incidents, I can absolutely see that that's precisely what we want to be accomplishing. but so I suppose I'm kind of just wondering really at the point at which the measures, the outcome measures that you really want to use, when we might be able to comment on those. Because I think that the outcome measures are so important in terms of ensuring that people are adopting the behaviours that we want them to adopt, rather than inadvertently pushing them in the direction of adopting others.
Thank you very much, Suzanne. That's one of the comments I was going to ask, that what would people want to know in terms of measures? Because if we're talking about the kind of quantitative measures, they're numbers that you want to be looking at, and then there's a qualitative part of it in terms of what's the quality of the care we're providing. So if for things like national benchmarking, which looks at numbers and looks at our caseloads, and even from what I know from going into some of our community mental health teams, it's unrealistic to expect a care coordinator to care coordinate 40 or 41 people. So caseload numbers is something that we will definitely have to look at. Because of the referrals from and to primary care is going to be a national indicator because of the primary care network, to show whether people are being managed within primary care or what is going to be the kind of neighbourhood offering. So there's some of those measures that are kind of almost nationally indicated that we would have to report. But I would really like to hear back that in terms of progress as a board, what are the things that people would want to know? Because that would help us when we're shaping what measures we're going to be using going forward. So I'm really open to any other suggestions. Ife?
I know Steve was before me. Steve, do you want to go?
Can't see Steve's hand.
Oh, sorry. Yeah.
Comment.
Okay. And there was just a couple of things. First of all, I love the presentation. I really liked it. I could understand it. You could see what it was trying to address and how it was going to do it. Oh, hello. I particularly like the stuff about outcomes and patients. Two thoughts really. One was, can we really do all of this at once? So this meeting has already talked about, you know, the fact that the acute wards are really busy, really busy. That there's loads of people in the local acute hospitals who shouldn't be there, who've got mental health issues, which is one of the things we're trying to do. And we've got an intermediate care strategy, which, you know, we probably haven't got enough money and we possibly haven't got enough staff, and we're going to have to do some interesting things. Can we do all of those things at once? Or what's the priority? And the other bit was about the outcomes. I quite like to see outcomes in sort of strings, so that you can see interdependent ones. So you reduce the number of people in the acute, but you also measure the number of people in community services and what the caseloads look like, and you look at who's at home and who's in respite, so that you don't get that shunt, or if you do get that shunt, you can see it. So if you personally, I like the strings because they're less manipulable, and you can see that you've addressed the whole. Well, we've addressed the whole thing across the board. But you know, I think it's a great start, and I look forward to seeing.
Thank you very much, Steve. I'll respond to some of that. What I didn't include in this pack was the driver diagram, and that's because we've just had the discussion on the driver diagram. So that will then show the link between what we're doing and the measures. So I hope I can use that at the next update and give much more meat to it in terms of what we're delivering so far. Suzanne, your hand is still up before I go to Ife. Okay, Ife and then Ian.
Yeah, so just a couple of things I wanted to say. The first being on the earlier point about families and whether families need respite and whether in fact they see caring for their loved ones in the community as a good thing. I think the other thing we haven't quite touched on is all too often what families say is that the provision is uncertain or is not good enough. And so if as part of this program we can address what people are getting in the community, that may well help us prevent people tipping over into hospital. So I think that's really quite important. I mean, my second point is more about the outcomes. I don't think there's any single measure or even two measures that will tell us whether this is working or not. I think it's got to be a basket. And so that question about caseload numbers or the threshold for referrals, well, of course, you want to check with GPs. You know, so it would be interesting, wouldn't it, if GPs are saying to us, we can't get anybody to you, and we're feeling very happy that our caseload numbers are low. So we need to think, and I'm sure Ian or others may comment on this, about what are the top measures that, if you look at them in the round, will give us a good picture of what's going on. And it's got to be a mixture, as I always say, of some quantitative stuff you can count, and certainly some qualitative stuff, which will be about feedback from people. Abby's point about the caseload was a really interesting one. You know, so we were seeing incidents, we were seeing people tipping over into hospital, and when we looked and discussed with a particular team, we found that their caseloads were very high. They didn't have enough staff. You know, and you can't really begin to address that until you do some work with the team in terms of recruitment, in terms of agreeing systems and processes for managing people. And we're now beginning to see the benefits of that. So this is work that, to my mind, is really, really important. And in fact, Steve, even your point about the pressures on acute, etc., if we get this right, if we really get this right, then our offer, be it in the community, and also our ability to manage people pitching up our ED in crisis and our use of beds will be a long way, miles better. You know, so this is really very important work, both across mental health and community, as has already been said.
Thanks, Ife. Steve, there's one other thing you said about, can we do this or can we do all of this? And we definitely will need to prioritize, but there's some ongoing projects that feed into each other. So those kind of interdependencies that you were talking about, I could already see when we were doing the scoping. So there'll be some things which will be the priorities, and that's what I will report back. But there will be other things that will sort of feed into that, and I will just give headlines on what those things are. Ian?
Thanks, Abby. I mean, I was going to touch on something similar, really, which is, I mean, this is a preoccupation of mine, Steve, which is about how all these different things fit together. Great out hospital care, zero delays. We have transformation programs for mental health. We've got a similar kind of thing with adult community services. We have agile working. We've got all of these things going on, and I think we are actively involved in a conversation with Morehouse, who we're working with a consultancy group around the governance of this. So there's something about making the governance proportionate, and as Abby says, it's, you know, looking at those interdependencies and how existing Abby and Lorraine, in terms of their strategic work, how we use the existing kind of programs to kind of get the results that they need. So that, you know, there's that bit. I think that Ife's point about outcome measures is really well made. You know, it feels quite elusive at times. We want to just boil it all down to kind of a handful of things, and then before we know it, we want to know about this, we want to know about that, and then we have a kind of whole suite of indicators. And again, that is a conversation, a live conversation that myself and other colleagues are having with Alison and her team, and how you kind of have that kind of a meaningful sense of what we're achieving at every level of the organisation. So I think we're getting closer to it, but we've still got a bit of a way to go.
Thanks very much, Ian. Any other questions? So I suppose my final comments is that although it does seem huge, it is sort of getting better in terms of knowing what's going on and in terms of concentric circles and us all working together. So I'm looking forward to giving you some updates on our progress whenever the next time I have to do that is. So I'll hand you back to Rachel.
Thanks, Abby. That's great. It's really nice to see kind of how many of these different strands of the strategy are starting to come together and starting to add value. So I think we're next going to look at two of our building blocks, and I think it's the quality management framework next. And Ife, are you going to be introducing that?
Yes, I am. I don't intend to use slides. It's in the pack. I'm just going to assume that colleagues have read the papers in the pack, so it wouldn't be as exciting as that is, I'm afraid. So in the interest of time, I'm just going to walk you through what you've got in the pack, and then I'll be happy to take questions. So of course, the paper emphasizes what I consider to be the most important building block, I say, which is about the quality and how we implement the quality management framework. We clearly discussed this in December. We had the opportunity at the strategic board to review this, and I feel fairly confident that my board members know about the components and also do remember the key enablers. So what we've done is to just give examples of what has happened since this was discussed in December, what we've done with quality planning, and you will have seen with the publication of our quality priorities that this has been done entirely on the back of the quality management framework, where we've used information from the complaints, from what we've heard from users and carers, etc., and national drivers to agree what the priorities will be. And so we've done that for all the other components of the framework. We also have put together some of our initial thoughts about next steps and critically how we propose to measure progress, drawing hugely on the work of Kekop, whom you may know was responsible for reviewing the health difficulties in Liverpool and has gone on to speak at quite a number of safety events about what an outstanding and a learning organization will look like. And so we want to use that framework that's in the paper, looking at those 6 broad areas to then assure ourselves that we are making progress. And then finally, and I think this is really a great thing that Vicky did, was to use a case study that's quite fresh in our minds and something that Matthew had talked to earlier, the CQC inspection of our older adult wards, and has used that in the appendix to just show you how the quality management framework, what can happen when the quality management framework is in action. That's really the knob of what is in the paper. And I'm happy to take questions. I see Suzanne's hand is up already. So Suzanne. No, Joe, I beg your pardon. Joe's hand, not Suzanne. Joe.
Thank you. Thanks, Sophia. I think it's a really interesting paper. I guess I thought it was interesting in the appendix to use that example. And I guess the question I then have is, because I'm thinking back a few years ago when we were seen as a leader in ligature management. And I think CQC said that to us this time, you know, go back and see what you did a few years ago. So the crunch for me is how does this approach mean that we can sustain this equality improvement in the face of changes in staff, other priorities coming and hitting us between the eyes?
Okay, so that's a really good question, because this is often where we fall down. We do a great job when we're pulled up, and then it all peters out. So I think there are a number of things that we've done. So if you think about the quality control aspect, where we already have a group that's looking at this and continues to look at this, we have the tool which already is on an iPad, and therefore staff are able to use this as and when it's due a review. But perhaps more importantly is the assurance aspect, which is the improving lives visit, which we're going to continue. And at every stage, we're going to be asking our staff what they know about ligatures, etc. So we like we did 4 years ago. On this occasion, we again provided people with photo books. So it's about how do we ensure that as new staff come into the organization, that their induction includes the use of the photo books. And so when we come to the Improving Lives visit and we ask them, that they're able to tell us with confidence what they know about ligature risk. And that information, again, we go back to that ligature risk group and will come to the acute care forum. So I think we've got it right. There's an improvement and then sustenance. And that's the key thing. If you, I'm sure colleagues have read this in terms of going forward, this is why we keep talking about real life data. Where we can, we need our staff to be looking at real life data to see how they're doing. So it could be iFox or the dashboard that's been designed for managers. And then the assurance reviews, be it audits or visits, is how we can then say, yes, we're confident that this is still being tackled. But you're absolutely right to raise that. That's been an issue, not just in Oxleas, but across healthcare. And now, Suzanne.
There was actually a question about the link between this building block, Iffy, and I've forgotten what number it is. It's the safety building block. Is that number 5? No, whichever one is it. Yes, next one, building block 3. Yeah. So, I mean, there's a considerable overlap, isn't there? Because the example that Vicky has given us is one of safety. So, how are these two going to be linked together?
So, the first thing to say about this particular building block is that it cuts across everything. So if you look at Alison's about informatics, etc., a number of the examples we've drawn in here have come from the work that she and her team are doing. Similarly, a lot of the stuff that we're going to be doing in safety and safety culture will rely on quality management framework, both in terms of checking out what's going on and the assurance. So what I want to emphasize is that these building blocks are in fact what they say. They are building blocks, and being building blocks means that they cut across. And our role, particularly when we come back to the board, and I hope this paper has demonstrated this, is that we're showing you how the links exist and where they are. And we're going to continuously see to it that quality management framework permeates the entire organization, both in terms of control and assurance, which is, after all, what the board needs to know, that there is assurance that the things that should be happening to improve quality of care are indeed happening.
Can I just follow that up?
Yeah.
Because I think that the quality management framework potentially sets a good framework for a safety management framework as well. And the kind of more closely things could be integrated, the easier it will be, I think, for us both to seek assurance as a board, but also for you as leaders to develop metrics which serve the achievement of the strategy. And so that was sort of what I was wondering about. And and I appreciate that the new patient safety incident response framework is coming into being, but that's not the sort of be all and end all of our safety framework. So I don't know whether I can see actually Jane's hand has gone up. So maybe Jane wanted to come in on that.
Thank you. We've actually picked up that point, Suzanne, through the patient safety group, and we've recently had a few workshops where we've completely reframed and refocused the patient safety group, so that we've still got some emphasis on planning and control, but we've really upped the emphasis on assurance and improvement, and it's really energized the group, and I think it's going to underpin our whole approach to developing that culture of learning and safety. It really isn't just about serious incidents and PSEFs, it's about the whole experience staff, patients, families have, and how we keep people safe within our services and as they flow across the system. So we're in early days of making it happen, but we really love the framework. We call it the safety management framework in patient safety, obviously picking out our domain. It fits perfectly and it is giving us a real opportunity here. So hopefully you'll get some reassurance that we are using it in real time in practice.
That's really encouraging to hear. Thanks, Jane.
Okay, I think that's me done. Alison, is that you coming next?
Yeah.
Thanks, Iffy. Yeah, that's right. Like Iffy, I haven't done a PowerPoint presentation. we talked at the board away day about the digital strategy and some of the infrastructure that we're putting in place to support the delivery of remote services. And this paper really hopes to put some kind of meat on the bones, and it reflects conversations that we've been having within my team and with clinical colleagues, with Abby and Iffy and Neil and others, and kind of emphasises how we're really going to need to work closely with the Great Out Hospital Care team and Zero Waste initiatives to ensure that we incorporate as standard a digital offering in every appropriate service across the trust. We really want to ensure that patients have choice and that we can truly tailor care depending on their individual needs. We also acknowledged, and it was mentioned earlier in the meeting today, about more work that we need to do about improving the confidence of both our staff and of our patients too. In reference to some of the good work going on in ALD, and Laurel, who's our programme manager for Oxcare, is working with a number of colleagues on how we plan to tackle some of the digital inclusion issues that we see, particularly as we're rolling out Oxcare. So in terms of the deliverables, there's some core infrastructure deliverables that we need to deliver as part of this programme, but we also need to work with the leads on the big priorities to ensure that digital really becomes that kind of golden thread throughout our pathways. And I guess the last point I wanted to pick out from the paper that's in the pack is really, again, what we've been talking about how we measure success. There's some ideas in there about how what we focus on, and we'll be working with the leads initiatives in kind of honing in on the real KPI that we'll be looking at in terms of how we measure our digital ambition. So that's really all I wanted to say, and happy to take questions.
Thank you, Alison. Looks like everyone is very happy with that. So thanks very much indeed. Thanks, Rachel. Is there anything else on this item? Suzanne.
Yeah, it wasn't a question. I just wanted to sort of back up some of the things that Alison has said. And I think there's one key point which has come out of our discussions at Infrastructure Committee and also with Alison and James when they were preparing this paper. And I share this with colleagues because I think it may be that your thinking wasn't as stuck in the same place as mine was. But, we agreed as part of the strategy that we were going to increase digital delivery. And that's the way in which this bit of the strategy is summarised. And I think it's really important to emphasise that that doesn't just mean doing more of the same. That in the sort of context of increasing digital delivery, to give you an example, when we were discussing Oxcare, giving patients access on a digital platform to their records and appointments and kind of additional widgets or apps that they might use also means that their family can be given access to that, and that then the whole kind of pattern of care starts to change. Is that you can move to a place where it's not just about saying, well, we do your care and this is how we deliver it. It's about saying we can use these digital tools to enable you and your family, or anybody that those that you choose and trust to support you in this, to be actively engaged in that support. And we can also offer you support outside of an appointment with Oxleas, because there are ways in which we can offer digital support. And I do think it's really important to understand that potentiality in this, that it is more than just doing converting a face-to-face appointment into an online appointment. And I think that's the ambition that Alison and her team have.
Thanks very much, Suzanne. Anything else from anyone else? Rachel, is that it?
That's it on the strategy side. Thanks, Andy.
Very impressive. Thank you very much indeed. And that was a really, really good discussion. As we move on to the next items, obviously we're going to give them our full and proper attention. But given we've spent a lot of time on the matters before, we'll proceed briskly if we can. Item 8, Ian, please, Directorate Reorganisation. Thank you.
Thanks, Andy. Message understood. I'm sure you've had enough of me already. So I think hopefully the paper is very self-explanatory. Essentially, it sets out the change that we're proposing to make around moving our adult mental health and adult community services that are currently configured on a borough basis to a service line structure. It sets out the kind of case for change, which I think we've discussed previously. the principles we're working within, and then it gives you an indication of the work we're doing in the background to get us to a point where we can implement the change. And the indicative date for that is the 27th of September, or around about that time. The points I just wanted to kind of reiterate, I'm kind of leading the change, but I have excellent project support from Ellen McGowan and Kay Abbs from Rachel's team, and colleagues on the exec I'm very grateful to, because they're leading the different component parts as set out in the paper. I just wanted to report back that we have now appointed to the 3 service director roles within the new structure, and we're in the process of appointing to the clinical director roles. The remainder of staff directly impacted by the change, which are the senior management teams, the business and service improvement teams, and the administrative teams that support the directorates. They are currently subject to a consultation which runs for 14 days, which commenced last Monday. I have held 2 meetings with staff affected, big meetings, and obviously colleagues will go through kind of individual processes, but that consultation is to have a framework for moving staff from their current roles into the new roles. And as the paper sets out, there's a number of other bits of work going on in the background around estates, IT systems. There's a comms plan that sits alongside that, and also just to clarify where services will sit in the new regime. And then linked to that, but slightly separately, ASRA is leading a piece of work using the opportunity of the change just to review our business and service improvement functions across all our directorates, not just the ones that are subject to the change, to just work out how we, look again at their purpose, what we want them to deliver, and how they fit into the kind of corporate department. So that's a piece of work that's linked to this change, but not integral, and it may take a bit longer than the other things that we're talking about. So I will stop there. Happy to take questions. Do you want me to do this bit, Andy?
Yeah, if you would, please. I think Joe first.
Yeah, Joe and then Steve.
Thanks, Nina. Very quick question. So yeah, you mentioned sort of various other services like estates and IT. I just had a question on finance, so budgets, because obviously it's important that once we reorganise everything, we've also reorganised all the budgets so we don't lose sight of where we are. So can I ask how that piece of work is going? I know finance has been incredibly busy on year end and ICS and things.
So one of the lessons that I was keen to learn from previous changes in Oxleas is that often we don't give enough time to kind of sorting out bits, the IT system, but also things like the budget line. So we have built enough time to do that on this occasion, and the timing of the staff consultation will then enable us to do all this other work behind that. So members of ASRA's team are part of that discussion around making sure that that everything is aligned, and then ASRA is very much part of the project team, and in terms of making sure that I keep everything cost neutral, and we're working very closely around that. I don't know, Azra, if you wanted to say anything more than that.
So I was just going to add in, that was obviously a very key aspect, making sure that the budgets were appropriately aligned, especially given the complexity of some of the planning arrangements that we've got this year. So fortunately, we'd never actually got rid of the shadow structure that was the previous structure we had about 4 years ago. So we've got a very quick switch that we can do behind the scenes around some of these budgets, but we'll also take the opportunity of some of the work that we are doing to kind of realign and refocus some of those budgets as well, which we will do across exactly the same time frame. So I'm confident we'd be able to hit that during the same period.
Great. Thanks, Ezra. Steve and then Yemisi.
Thanks, Ian, and thanks for setting out the rationale so clearly. Just touching on lessons learned, I think for the board, when we had the last change over to a borough-based structure, we weren't sufficiently focused on outcomes and what we actually achieved. So I'm totally behind this change, but I think sort of give it a year, let's say September 22, it'd be good to come back to the board and just say to us what's been learned, what's worked, what hasn't, but particularly around have things such as productivity improved and feedback from staff, so that we don't, you know, so that we can see it has been hopefully been successful, which I'm sure it will.
Yeah, no, I think that's a really good challenge, and I suppose linking it back to the previous conversation. I mean, my view is very much that this new structure will enable us to really kind of maximise the potential to deliver those outcomes set out in the strategy. So I think everything will be lined up nicely, but yeah, we need to make sure that we review it thoroughly. So thank you, Yemisi.
Yeah, thanks for that, Ian. Just really quickly from me, have we anticipated any challenges that could delay the rollout or affect how efficiently we do the restructure? Just off the top of my head, I'm thinking there might be further updates within the ICSs that could affect it, you know, COVID wave 3. They're just things that might impact it. I just wanted to know your thoughts.
I think well, the short answer is no. I don't think there is anything that's going to stop us doing it. I mean, one of the kind of key bits of the time leading up to the implementation is to really make sure that the new service directors are fully cited and briefed on the work that colleagues have been doing in areas that they're not currently working in. So there's a whole series of conversations so that we make sure that we have business continuity going into that kind of implementation. And again, that's a reason for making sure that we get all the work around the IT systems done well before we make the change, because previously we've been paying catch up for like 6 months afterwards. But in terms of the ICS, I mean, commissioning discussions, quality discussions, they're very much on the service line basis. And one of the reasons for kind of making this change, it enables service directors to get much more involved directly in those and have much more kind of authority. So I think that's working well. I mean, I think we've talked about this already in kind of previous conversations. I am and other colleagues are doing quite a lot of work to reassure place-based colleagues, so at borough level, that Oxleas moving to a service line structure is not kind of going to negatively impact on those place-based discussions, because we can do both. We can, I think firmly that, you know, this is the best way of managing quality and performance within Oxleas, but we can still have that borough level focus in terms of service delivery. So there's a lot of work being done around you know, mitigating any potential risks of the change in that area, but also offering reassurance to the system. So yeah, I feel confident that nothing's going to knock it off course for September.
Thanks, Ian. I was just thinking about the comms plan. We know this from before, and I'm sure it's in hand, but just keeping some very simple messages about why we're doing this, what the benefits are going to be, so that we can repeat these quite regularly, because it does get lost in the everyday busyness of people who sometimes can see it as just another restructuring, whereas we need to just reiterate why we're doing it and the benefits that we see coming from it.
Absolutely, and I feel confident that Sally's put together a really comprehensive comms plan, which absolutely has that kind of running through it. Okay, lovely. Anything else for Ian on that? If not, thanks very much. And we'll go on to the freedom to speak up, please, Rachel.
Thanks, Andy. I'll be brief. There are just 4 points I want to make. So you'll have read the paper from the Guardian service. and you'll have seen that we had 20 cases in the last 6 months. And what Steve James and I asked the Guardian Service is whether or not that's about the right sort of numbers for an organisation of our size. If the numbers were a lot higher, that might be cause for concern, but if they were a lot lower, that might also suggest that people don't know enough about the service or that there's something of a climate of fear. But reassuringly, they say that these sorts of numbers are the sorts of numbers you would expect for an organisation of our size. And the numbers are also pretty representative in terms of ethnicity and gender, but perhaps a little bit less so in terms of location. So there are some interesting differences by location that you will have spotted. So you'll see that the paper refers to 3 safety issues, and those sorts of issues include both patient safety issues and staff safety issues, and all of those are taken very seriously. The types of issue being raised here, just to give you a flavour, are things like the appropriateness of a particular restraint, or of staff sleeping on night shifts, or ensuring that staff are well protected against violence from patients. So important things that we unpack and investigate and make sure that we reach a good conclusion. Fortunately, the Guardian Service do say that we've got a good reputation in terms of senior leaders right across the trust taking these issues very seriously and promptly when they're raised. And that really makes a difference, I think, in terms of being able to act on the things that our staff are telling us. The other theme that comes through clearly from the paper is about manager behaviours, that sense that sometimes our managers communicate a bit abruptly or show poor behaviours. Now, we do know that there's real pressures of work at the moment and have been over the last 6 months, but this is clearly something we really need to tackle, because that sense, that tone from managers really impacts our staff experience and can contribute to people leaving the organisation. So we want to tackle that through workshops, going through our new values and behaviours. We're also going to be introducing new leadership and management programmes that we want all our frontline managers to be undertaking over the next couple of years. And compassionate and inclusive leadership will be right at the heart of all of that. You'll also see that staff are often approaching the Guardian Service because they feel either that they won't be or haven't been listened to by their managers. And we really wanted to understand this and unpack this with the Guardian Service. Their sense is that this isn't about a culture in terms of our senior leaders, but rather that some frontline managers who aren't taking the time to listen and engage with their staff are making some of team members feel as though they're not being heard. So again, getting that communication right and people feeling valued and heard by our managers is so important. So we're going to be working with managers to get that we listen part of the values right. But generally, I'd say that the arrangements of the Guardian Service are working really well. Steve James, Matthew and I meet with them very regularly. They're getting out there on the ground, they're meeting people in person. Their findings help to inform what we focus on as a team and as an organisation, and they help get the message out there about the things we're trying to do to make Oxleas a better place to work. So that's what I was going to say, but I would welcome questions.
Yeah, I think we've got Nina and then Steve, I think.
Thank you, and Rachel, thank you very much for that overview, because you've answered very helpfully a couple of the questions that I had. The remaining ones are really just to try and understand 2 points. There were a couple of concerns that were flagged as red, and the report indicated that the Trust was still looking at them. So I just wondered whether there are particular issues there that we could hear about in terms of why they're taking a while to address, and whether also we are drawing out lessons for, if there is a particular instance that relates to clinic setting, whether we're drawing it out for other areas of the Trust rather than just focusing on the area where the issue is raised. And I also wanted to welcome the introduction of the Prison Workforce Committee and ask if we could please get them along to one of our future workforce committees. I think those deep dives would be really helpful.
Thanks, Nina. So some of the 2 of the questions that have been raised that haven't yet been finalised are being fully investigated at the moment. So they are in the midst of a kind of a detailed investigation process about what happened. So the service directors lead on those and work in a local area to try and make sure that the right areas are addressed. And then we feed that back to the person who raised the issues, and we make sure that lessons are learned. So what they do say, as I mentioned, is that our service directors are really prompt at acting on these things. Other organisations, people need a lot of kind of pushing to respond to these things, but we've been responding really promptly to these issues. So as soon as they reach a conclusion, because they obviously have to go through a bit of a process, not all of them are easy ones to resolve immediately, then we capture the learning and try and make sure that we spread that. And very happy to bring them back to our workforce committee. I had rather hoped to bring them to the July committee, but a combination of serious illness and pregnancy has meant that our normal Guardian service representatives won't be back until September. So I was thinking we might wait until they were back. Not sure who was next. Was it Suzanne? No, it's Steve. Next, thanks.
Thanks. It was just a comment. I think that the regular meetings they're an impressive organisation, and I think that we can have assurance that they offer, a dispassionate service to the staff, and all the questions that Rachel's covered are the things that we ask. I suppose the only thing that still continues to bother me is that people use it because they believe they're not going to be listened to, or they have had a go and they haven't. Given that these are small numbers, so that's the other, we have to remember there are small numbers and we have to try and work out what that means. But given that most of the people who use this service that are in the Guardian Services categorisation workers, that must mean that most of this relates to junior manager, first, second line managers. I don't think it relates to senior people, because I don't, knowing them, I don't think that would be true. So we really do need to concentrate the training on first and second line managers, because that's what that information is telling me. So I look forward to, I know we're going to do that, but hopefully once we've done that and people feel a bit more confident about being challenged, those figures will, well, maybe the usage might not drop, but the way that it's configured at the moment might alter, because it is worrying that the majority of those things are in those two categories.
Thanks, Steve. And it is the Band 6s and Band 7 frontline managers that we want to go through a programme of leadership and management programme over the next couple of years. And we want everyone in that category to have had that training over that period, starting with the people who haven't had any training yet, but we want to cover everyone. And we're working closely with Christine Capopo and others to make sure that we do that in the right way, so that it doesn't feel too burdensome on the organisation as a whole. But I think it will be a real investment, and I think it will be the best way of tackling these sorts of issues. Thanks, Steve. Was that your hand still up? Did that answer your questions? Thank you. Suzanne.
This is just a quick thing, but my jaw did drop a bit when I read this in the report. It's on page 117, and the Guardian has written that some people have neither had the courage nor the opportunity to address the matter directly with a line manager. I think that's really insulting to our staff. I don't think they lack courage. I think that sometimes staff can take a view that they don't want to be chalked up as being a troublemaker, that they don't want to jeopardise their career, that they don't want to get a bad name. And I don't think it's to do with courage. And I'm surprised, actually, that a service that specialises in hearing freedom to speak up issues would regard it as a lack of courage. And I would really appreciate it if you could take that up with them. And, I hope that staff who have used the Guardian service won't see this report and feel that they're being, that it's being implied that they lack courage, because I don't think that's the case.
Thanks, Suzanne. That's an important point, and I'm sorry I didn't spot it. I could have probably challenged it if I had spotted it and seen it in that context. Generally, I think the feedback that we get and the nature of the people who are involved in this case is that they are extremely pragmatic and supportive of staff, and that is the sense that we get back from people. But I agree with you that it could have been described much better than the way that it was. So thank you for highlighting that.
You got Nina and Stephen Dilworth, I think, still.
Sorry, Andy, I didn't have anything further to add. Sorry if my hand is still up.
Okay, Stephen Dewar.
Thanks, Andy. Thanks, Rachel. And as you say, I think the numbers are sort of in the right sort of scale, aren't they? Not too excessive and not too low. Two things from me. Just a reminder for everyone that internal audit gave the process a very favourable report back in March. Significant assurance with minor opportunities. And then the other thing I just wanted to mention at page 7, where the Bromley Directorate seemed to be a bit of an outlier. And checking back on the branch visits, the board visits that we've had this year. So I've done with Lorraine 5 and Iffy. And in 3 of those, there were issues that were in the course of being resolved. So, and they're all different. One was about senior leaders all departing at the same time. Another one was about vacancies. Another one was about high level of complaints. But the key thing was they were being resolved. And so I'm perhaps being optimistic, but I'd like to think that that may have fed through to some of the complaints. And I would like to think that perhaps on the next report, we see that level for Bromley would have been reduced. Ian or Iffy might want to comment on that, but hopefully that's the way it will go.
Thanks, Steve. I will say that when people have had a positive response back from the Guardian service, they do often tell their friends, and sometimes that kind of can lead to more people engaging with them as well. So we sometimes see clusters where people have thought, gosh, they seem to have had a good result there. I might go and talk to them as well myself. So it's not always the sign of something being wholly broken in a particular area.
Thanks, Rachel. Anyone else still waiting to speak on this one? If not, I'm very grateful. Thanks very much indeed, Rachel. Very good, thank you. We move on to Jane and safe staffing, please.
Thank you very much. The paper's been through the Workforce Committee, so I'll just pick out a few highlights. We continue to monitor safe staffing in real time and flex to meet the acuity demand as the services require them. And the matrons and ward managers are continuously using professional judgment as their gold standard. We have now managed to get the mental health optimal safe staffing data, which Christine is currently analysing for the next establishment reviews. So that will give us some information about whether we need to make further changes to the establishments. Following the Workforce Committee, we looked at the care hours per patient day and the comparators, and we're really struck that Oxleas was comparing the medians quite low to other areas. So having dug a bit deeper, we've identified that there are some anomalies with our rostering and our reporting coming off of it. So we've met with the health roster team and with Rachel and Azra, and that is being rectified at the moment. And an example of that is the allied health professionals are not being counted pro rata. So they may be working in 2 or 3 areas, but they're not being reflected in that way. So we want to make sure that's accurate. A big focus throughout the pandemic has been on supporting the staff wellbeing, and we've really focused on the ward managers who have had a really tough job over the last year. We've successfully run 1 action learning set for 8 ward managers and have commissioned a further 2. They were very well evaluated, and we're currently supporting ward managers by carrying out the Maslach burnout inventory assessment so that we can map their progress and give support where it's needed. A couple of projects in development are to develop a safe staffing tool for prisons. There currently isn't any in existence, so we've been talking to people in Mersey Care who are also interested in developing this. We're going to start with Wandsworth, and we're looking at developing a tool for district nursing. And I'm really pleased to say that Christine Kapopo is undertaking her fellowship in safe staffing, so we should be able to use all of the most up-to-date tools and techniques over the next year or so. And she's working really hard at that, so I'm very grateful.
Stephen, please.
Thanks, Andy. Thanks, Jane. Jane, I was just trying to pick up from the report what was your biggest concern, if there was one. So is there something in there that really hits you as that we should be aware of?
The only area that we do have some concerns about, and I know that the Greenwich Directorate are taking action around it, is the staffing at the Tarn. It was picked up at the last Safe Staffing meeting and continues to be a challenge. I did a board visit there last week, and I was really pleased that there is considerable engagement from the ward manager, the matron, the service manager, and all of the team in terms of looking at how they can make the Tarn a really sort of safe and feeling secure place to work. It's not just about the safe staffing, and they're looking at things like wider environmental changes, improvements, CCTV, looking at how they can improve the flow so that people step down from the intensive care unit more quickly, as well as looking at staffing at night. And they're currently in discussions about the number of beds on there. So if I was to say there's one area we should watch closely, it would be that area, and we have identified that previously.
Nina, please.
Thank you, Jane. Thank you for the report. I think for me, it's this really illustrates the difference between an exercise of doing safe staffing at a kind of point in time and the formality around that, and the reality of what you've had to do during the pandemic, which has been real life kind of exercises twice a day, as you've highlighted. I was going to ask a question about the Tarn. Thank you for the update on that. I just wanted to ask for assurance around the systems issues that you've highlighted in terms of the rostering, because we had a similar issue at Workforce last time where there was a question around the extent to which our internal systems speak to each other as regards health and safety and HR. And I just wanted to make sure that across the piece, we're looking at this comprehensively, because I'm a bit nervous that systems aren't talking to each other and we're missing things out. And that should be the more straightforward stuff to fix.
I'm not a technician who's fully competent in how the back end of health roster works, but we are really lucky that we have a fantastic new member of staff called Agatha in the HR team. I think she's an associate director. She comes with all the skills, and within the first few days of us highlighting that we found these discrepancies and we were curious, she'd absolutely pinpointed where the issue was in health roster and is tackling it head on with trying to get it right. This is going to involve work with the teams themselves, with the services, with finance and with the rostering team. But it is doable. It's just going to take a bit of time. But I feel pretty confident that with Agatha leading this, that it will be done and we'll be able to have our internal and external reporting done properly. I don't know if Rachel wants to add anything because she's been part of these discussions as well.
Only very briefly, Jane. I would say it's never straightforward to get all of these systems speaking to each other because there are a huge number of complexities with it. But I think we're on the case in terms of understanding what's not working here and have a good plan for getting it sorted.
Thank you, Jane. Any other questions for Jane at all? If not, thanks very much indeed. We'll go into Mortality Committee, please.
Thank you. Again, this report has been through PQAP, so I'll just pick out a few key points. In Q4, we reviewed 350 deaths. Mostly they were expected natural causes and not surprisingly remain highest in community healthcare with end-of-life care provision. The overall quality of care scores, as we're still picking up problems around engaging people from support networks and some information around risk assessments, which we've discussed before around objectivity and informal patients. We're now trying to log the learning from each of our meetings and reflect on what needs to be done to make improvements. Some of the themes that have been coming out over Q4 was really around the inequalities of people with serious mental illnesses and learning disabilities. So a deep dive has been carried out into the serious mental illnesses in Bromley to see what lessons we can learn. Again, for learning disabilities, we identified a risk of people with mild to moderate learning disabilities potentially falling through the gaps, specifically when they're having episodic care and they weren't on somebody's caseload. So there's been a real awareness raising and extra vigilance around this. We picked up on the increase of end-of-life care in Eltham community beds. They've never had this level of end-of-life care, so the pandemic did make some changes to the types of patients and the care they were providing. And an end-of-life care nurse, Charlotte, has been appointed in Greenwich and is supporting them with that. And as we've talked about earlier in the meeting, we were looking at the vulnerability of prisoners, particularly at times when they are receiving news of a lengthy prison sentence or they're returning to a different cell, noting that there's a real high turnover. We're particularly interested in Wandsworth and Thameside are now piloting a high-risk, high vulnerability list, and we're hoping that they'll share that information between them. And then finally, we looked at the NKISH real-time analysis of suicides during the pandemic, which showed that there hasn't been a rise during the first lockdown, despite the increased distress. But we're remaining very vigilant about monitoring that, because for us, it's really early days and we want to make sure that we're not missing anything. Thank you.
Thank you, Jane. Any questions for Jane? Steve, James, please.
It was just a quick one around the learning disability deaths. They ring alarm bells for me, because if you can see two, you can be absolutely certain there's loads more behind that. And so I think there's a thing about being inquisitive about any do not resuscitate that you see. They're not necessarily wrong, but they often are. And I think there's been a number of organisations that have been criticised for just accepting somebody else's do not resuscitate. So I think we're well placed to question them, because you would be surprised how many of them have got learning disabilities as the reason. And we really got to stamp this out. So any opportunity our staff have to look at people with learning disabilities records, just to check that out, we really ought to take it. So it is about awareness, but there is a foundation. You know, there are a lot of people with learning disabilities who've got that on their health records, and it's scandalous, to be honest. So we're well placed to try and do something about that.
Definitely. I know that the learning disability teams are on the case and already looking at that. And we totally agree, it comes out of leader reviews regularly, and it just isn't acceptable. We need to be leading in making sure that this changes.
That's a very good point, Steve. Thanks for that. Thank you, Jane. Thanks very much. We move on to item 12, the MSc PQAC, please.
Thank you, Andy. I can be incredibly brief. A lot of our agenda items we've discussed during Ian's update, and Matthew has mentioned a lot. So I just wanted to focus on those areas that we haven't really had a chance to touch on. First of all, I just wanted to give the board assurance on our directorate presentations. We've been doing them for a couple of years now, but I think what I'm beginning to see is just the increased quality in those presentations from the directorates. They're really thinking about their quality governance within the directorates and their challenges and the actions that they've got against them, all the mitigations, and bringing that to PQAC. So we had over the last 2 months in Greenwich and Bromley, and they were two very comprehensive, robust presentations. So just to give assurance on that. And then the other aspect was as part of our improving quality governance framework that we've been talking about, the committee, we approved the QIA assessment process that we've now got in place. So in effect, we've standardised how we implement QIAs across the board. So we approved that, and also there's an element of it which has a NED-led review for high profile or problematic QIA. So we approved those two aspects. And then we got updates on the current transformation plans, which is all in the report. So that's what I was going to say in terms of an update from PQAC, but happy to take questions.
Thanks, MSc. Any questions for the MSc at all? If not, thanks for everything you're doing on that committee. It's such a huge workload, isn't there? Covering so many different topics, but well done. Thank you. Move on to QI. I mean, Iffy, are you able to do QI, please?
Yes, of course. Thank you, Andy. Just very briefly, again, paper is there. Just 2 or 3 things I want to draw attention to. You see that there were 3 feedback sessions, a couple to do with specific projects from frontline staff, and the third was from Bexley. And you'll also see in there that what we've started doing is asking the question about who else might benefit from this project and how do we invite them to learn more from the team that have just completed the project, which is all in line with what we're trying to do with respect to scaling up. You'll also see in there that we've got updates on training, sorts of projects we're running, and this additional priority for us this year, which is about the involvement of service users. And that's really an area that we want to get a handle on, so that we'll get to a position where with every QI that we undertake, particularly those that are aligned to our strategic values, that we have service users right from the outset and through the QI, and indeed have service users supporting us with the scaling up. That's what I wanted to say, and I'm happy to take any questions.
Thank you, Iffy. Any questions at all for Iffy on that one? If not, thanks very much. We'll move on to Business Committee. Jo.
Yeah, again, happy to take the report as read. I'll just highlight 3 things. So one, as you can see on the sort of the financials, we are underspent, so generating a surplus. We needed to underspend a bit in H1 in order to meet our plan of break even. But we clearly need to get on and start spending some of this new money now, and there's quite a lot of plans in place to do that. Secondly, there's a note on various of the prison bids. I think we're generally up to speed on all those. The one I wanted to highlight was the dialysis bid, which hopefully, I'm not quite sure if it's signed, sealed and delivered yet. I'm looking at Ian to see if he nods or shakes his head. But that was something that came to us pre-COVID and then got stalled, and that is to provide a more permanent dialysis unit for prisoners at Thameside. And you can imagine that with an ageing prison population, increasing prison population, taking prisoners out for dialysis takes a lot of resources. So that just worked. And the one query we had on that when it was first raised with us is, if the number of people going through dialysis goes up, are we exposed? Because clearly that wouldn't be great. We're really sort of priming this contract, but it's pretty much flows through with the subcontractor through to the commissioner. And the third thing I just wanted to mention, which is the last item in the covering sheet, is the bridges debt. This is a historic debt where the company that owed us for some rental charges for premises went into liquidation after what might be considered some interesting intergroup transfers of money out of that company. And this has been rumbling on for too long, really. So this matter is now at a head, and we are seeking further information and advice of whether we are going to fund a visit to a QC to get some detailed advice on that. So we'll be taking that forward to decide ultimately which way we go on it. They were the points I wanted to raise. Happy to take questions, as I'm sure is Azra.
Any questions, colleagues? If not, thanks very much. I've still got the floor, Jo, with partnership.
Yes, again, a very short update on partnership. We didn't actually have the partnership committee that was scheduled because there wasn't an awful lot to go to it. There's obviously lots of stuff going on at the ICS, but I think generally people are up to speed on that. And SLP is very much into looking at the future, and there's a strategy day shortly on that. Probably the one thing's worth mentioning is we had a good partnership meeting on the 18th actually of June with Lewisham and Greenwich Trust. It's fair to say that since we started those partnership meetings, I think a year or so ago, relationships at a number of levels are much improved, and we have initiated a very small working group, including Ben and Matthew, to look at other areas where we think collaboration will be worthwhile. And I don't know if it's worth Matthew speaking about that, but with a very short timescale to come back to us in September and sort of, you know, with a sort of a menu of areas that might make sense.
Yeah, I suppose just to say that, you know, over the last 12 months, both in terms of what we've done around crisis mental health presentations and also the Home First work, there's been a couple of really fruitful areas of joint working with Lewisham and Greenwich Trust. You know, we've addressed some of the sort of real points of friction between the organisations head on, and in the process, we've managed to improve flow, improve the sort of patient experience, and also improve the way in which our staff work together. So what we're doing is just looking to see if there's any further areas of collaboration, thinking about the importance that place is going to have in the new legislation, and how our ability to work, you know, more in depth at place within both Bexley, Greenwich, and also in Bromley, and outside the LGT remit. How we really explore that going further. So what we're doing is kicking the tires on where can we work together to good effect, very much informed by the principles of the South London Partnership, which is what can we do better together rather than as individual providers, and to start from that premise of what are the best areas of care and the best pathways of care for us to focus on, rather than thinking about the governance and structures first. You know, we'll think about the outcomes first and then think about how we can do to get there. So that'll be reporting back in September.
Thanks, Joe. Thanks, Matthew. We move on now to infrastructure. Suzanne, please.
Thank you, Andy. In the interest of brevity, I'll assume that the cover sheet has been read. I only wanted to bring one item to people's attention. It might have jumped out at people that the anti-ligature work on the old people's mental health wards has been further delayed, and the completion date is now around March 2022, and that's probably optimistic. I just wanted to explain what that delay is. Part of it is to do with the hardware not being available, and this is an impact of COVID closing down factories that are creating porcelain ware, I think. But the second reason for it, which is a matter of some annoyance to all the members of the committee, is the behaviour of the PFI lenders, who are now demanding letters of assurance before proceeding with works of this sort. I've asked Rachel to explore the possibility of pursuing some preliminary legal discussion about this, as I think anti-ligature work is, in my view, a safety critical adaptation and not something to be delayed by these financial concerns of the lenders. And Rachel's going to come back to Infrastructure Committee with her findings on that. So that I hope that you know, it'll be resolved hopefully by March 2022. We did have a discussion at Infrastructure Committee about the risk, the continuing risk that this presents, and have been assured that the clinical management of ligature risk, which we now have in place, and the understanding of our staff in how to manage the continuing risk that this represents, is satisfactory, so that whilst it's an environmental risk that remains, we're managing that risk as well as we can.
Well, that's a real worry, isn't it, Suzanne? Yeah, we can't really say to the coroner or the CQC it was sort of PFI's problem, you know. So I'm grateful, good to hear that we're going for some advice on this, because this is obviously a real anxiety. Matthew, you got any thoughts on this?
I mean, the PFIs are real. It feels sometimes like they're the real law unto themselves. I mean, we have tried escalating sessions with them in the past, pulling in people higher up the chain, and sometimes that does work as well. So I think let's take some advice on what we can do to try to intervene, perhaps at a higher level. There, you know, it's an eternal source of frustration. I know Rachel and her team work hard to try to unlock it. Yeah, we'll try to follow this up, because, as you say, Andy, it's not a justifiable excuse in the context of the risk to the patients or from the regulator's perspective.
Now, you think to yourself, if we just gone and did it with somebody else, what's the risk to us from the PFI? If we're saying this is patient safety, we're saving people's lives, and you're holding this up, and I'm always worried about our mitigation, because, you know, I think it was mentioned earlier in the meeting, we go back to 2016 when we commended for best practice, which then sort of fades away after a while with new staff and agency staff and bank staff and all the rest of it. and fatigue. This is something really quite serious, isn't it? And March 22 sounds like an awful long way away.
I mean, Rachel teased on, so she might have a view on whether there's anything exceptional we can do. I mean, one option is to get it costed up and say we're just going to go at risk and pay the fines further down the line. I think the issue then is that they won't do any maintenance on anything we do using someone else. And we'll end up in a right old mess. So, but I don't know if Rachel's got anything to add.
I think that's right. If we do the work, we're effectively changing their building and their building structure. They'll stop doing the maintenance and we'll be responsible for anything that goes wrong within that. I think Kings are equally, this is an issue at Green Park's house, not at Oxleas house. So Kings are equally frustrated because it's a new process the PFI partners have put in place to seek a kind of side letter to reduce the risk to them, essentially. And we are working with Kings to try and address it, which is partly what will make any legal letters difficult, because our letter would be to Kings, who actually we're working alongside because we don't have a contractual relationship with a PFI at Green Park's house, which is part of the complexity that makes it difficult to manage.
I mean, one would be to try to get the region to weigh in on this, and say, look, we've got NHS England on, I mean, there will be people higher up the chain somewhere who know someone who's on the board of the PFI company or whatever. Although I have to say that if my memory serves, I think the company that owns the PFI at the Green Parks are an American. It's been bought out so many times, I've slightly lost track of who owns it because they get sold every few years to different pension funds and various other things. But that there might be some merit in speaking to someone regionally to see if they can bring some additional pressure to bear to help us and Kings out with it.
Is it a big deal, this letter of assurance? I mean, is that a problem for us to do?
And it's not for us. I think we would be happy to sign something if they would present it to us. I think it's them, and it's not even the PFI partners. It's the lenders. So it's the people writing. It's the the people who've lent the money. And to be honest, they're not particularly focused or cited on what it is this money's all about and what it's delivering. They're more focused on the financial impact. So it's bringing it to their attention, which is why I think a legal letter might be helpful, even if it's just to bring it to the attention of the right people.
Yeah, I do think, Matthew, if we exhaust, and Suzanne, if we exhaust this bit, but I think we need to raise this by the ICS or other political level. Perhaps not so much ICS, maybe it's more at NHSE level, and get governmental involvement, because this is not acceptable, is it? That this delay for something of this risk, it really isn't. Joe.
No, I agree with that. I mean, I saw that day and my heart just sank because it's been delayed so many times. I agree about trying to get some sort of purchase higher up the organisation. I also wonder whether, when we're talking to our lawyers, whether we can very much explore with them the route that can we just do it and then effectively allow them to sort of retro review when it suits them and then get it back on maintenance. Because you're absolutely right, Andy, if something happened, they're not going to be in the dock. We are, and we should do what's right, I think. So I think we should seriously explore about actually just doing the work.
Okay, Suzanne, any thoughts?
I mean, Rachel and I are due to have a further conversation about this, and I'd be interested in the nature of the legal advice, because, I can see that within contractual context there might be difficulties, but I can't help thinking that there might be an alternative legal route. But I'm not a lawyer myself, but I'm starting to think about possibilities that there might be.
Thank you.
Yeah, okay, Suzanne, that's helpful. I was just thinking, I don't know, Matthew, you know this well better than I, but do we talk to CQC about this? Do we talk to HSE about this?
I mean, CQC will be mildly interested, but not that interested, in that their view is it's our responsibility as a provider to sort it out. So I think it's more, as Azra said, the NHSEI cover. I think the doing it ourselves option might make things better for 3 to 6 months until the building starts to run into problems. and then the PFI will say we ain't coming into that ward. You know, you've altered it, and therefore you've broken your contract, therefore you're responsible for that ward from that point onwards. And we then end up having to provide our own hard FM providers within the trust to address the problems that are within a PFI building, and that could get very, very messy. So I think the lawyer's letter, I think for us to then talk to King's then about how we jointly try to get the regions help with it, because the best thing for this is to raise it to the attention of someone significant in the PFI. I mean, I don't know what the sort of liability looks like in terms of if there was further injury to someone as a result of the delay on the PFI provider and allowing us to do essential works we've identified, and whether there'd be any sort of serial liability for them as well. I don't know if that's within the scope of the advice we've asked the lawyers from.
We will certainly follow that up with the lawyers and ask that question.
My guess is whether this ends up at ministerial level, because I suppose we wouldn't be forgiven for failing to raise it. Will be up the line. You know, this government ought to have influence in these matters. Let's go through the right process, and clearly recording everything as we do. But I wouldn't want us to wait too long on this before we elevate it to a series of next levels, and including ministerial, because I just don't think we can carry on like this. I just fear that we'll end up getting another one of these, you know, standing in the dock again and saying, well, it's their fault, not mine. You know, and that's just clearly not going to wash. Most importantly, it's a risk to our patients. Anyway, okay, thanks very much. Anything else, Suzanne, on infrastructure?
Not that I feel it needs to be brought to further attention.
Great, thanks very much. Workforce, please, Nina.
Thank you, Andy. Again, very briefly, I'll take the report as read. We were delighted to have Abby join us formally, or I think that gets formalised from July, and we are looking forward to having her as part of the committee and helping us increase our focus on medical workforce issues. We received the annual Guardian report from Israel, and we had an interesting discussion around this on two fronts in particular. You'll see the report says that we have a low fine rate compared with other trusts, and the position of the committee was to challenge whether that's actually the right answer, whether we've set the bar too low, and whether it's because of positive action on our part, or whether the bar hasn't been set at the right level, that's why the fines are coming in at the level they are. We were assured on that front. Similarly, we asked the exec to please take forward as a matter of urgency the issue of locum consultant access to Rio, which has been ongoing for, it feels, too long. Segue into health and safety. I don't want to preempt the discussion that's coming later on in the meeting, but you'll see that there is a proposal to tweak our governance from a board perspective on health and safety with the introduction of a new committee. Workforce committee reviewed at a very high level, and we will drill into more detail in July, the first cut of the first year of health and safety audits. The report says it's the first year of audits. It's not the first year of audits. It's the first year that they've been done using the new iAuditor system. And there was a mixed picture there. There was some considerable variation, some areas that had done well, some that had done less well. But as I say, we're going to be drilling down into detail at the next meeting. We had an update on the many different strands of work that are ongoing as part of workforce, building fairer Oxleas, leadership development offer, the work to improve the health and wellbeing offer for staff. And we very interestingly looked at the detail of two policies, one of which was the recruitment and selection policy. And as part of the changes that have been introduced following building fairer Oxleas, we were very pleased to hear that every panel must now include a member of staff from a BAME background. So that goes to visible changes that members of staff can see, which I think is really important and has been rightly the focus of the building fairer Oxleas work. We also examined the gender pay gap report, and I might hand over to Rachel, if that's okay, to just talk through the headlines of that. And we have already heard from Jane on safe staffing, so nothing more to add, but happy to take questions.
Thanks, Nina. So on gender pay gap, it's steadily moving in the right direction. It's still something we are looking at as an organisation, but the big difference this year has been in relation to medical bonuses, which were distributed on an equal basis to all people who are eligible, and as a result, we haven't got a disproportionate distribution in relation to bonuses, and that does affect the position overall. But that's all I think I would highlight here.
Thanks, Raj. Those medical bonuses, is that national policy or is that an Oxleas policy?
Can see if he's switched off his...
Critical Excellence Awards and its national policy. The change, however, has been that it can be determined locally, but it is national policy, locally determined.
Yeah, having sat on one a few years ago, it's an interesting process, isn't it?
It has changed considerably since then. You'd be interested to know, Andy.
Very good, thank you. Just on the boards, the selection panels, on service director, was there an issue there about the representation on the panels? Because we invited people from other services, didn't we, from outside? And I'm just wondering, did we end up with the right selection panel for that? Matthew?
I think that there was an issue in that most of the people in senior positions in most of our partner organisations are white. And so as a result, when we invited sort of senior stakeholders from the CCG roles and local authority roles, it's almost entirely white men in those posts. And as a result, that panel was less diverse than we would have hoped it would have been. And I think our own internal panels and our own stakeholder panels were a better balance. But we are in a position where all the directors of adult social services, children's services, every CCG lead, etc., outside of Oxleas in South East London, certainly in our boroughs, is white, and that meant that panel wasn't as diverse as we would have liked it to be.
Okay, thank you. Ian, did you have your hand up?
Yeah, I was going to say exactly the same thing.
Okay, thanks very much. Anything else, Nina?
No, thanks, Andy.
Thanks very much. Audit and risk, please, Stephen.
Thanks, Andy. Just a couple of things to update people on, and no doubt Azure will come in at the end. First of all, the timetable, obviously due to COVID for 2021, has had to be slightly amended and adjusted, but the audit findings, which I think is the key piece in a way, has now been completed, and I'm pleased to report there's nothing that Grant Thornton got upset about or are going to qualify. There was an item regarding valuations where they gave a gentle shot across our bow, where we've changed the method. We have a choice really for valuing the estate as to whether we class ourselves as Outer London or Kent, and we have changed it over the past couple of years, and what they're quite rightly saying is that there needs to be some consistency on this, so don't keep changing it every other year, which is perfectly fine. It's not a qualification to the accounts, but it's something we have noted and we will comply with. On to internal audits. The internal audit review by KPMG for us as an organisation over the year was significant assurance with minor opportunities. And that again is a very good report for us. It puts us, we asked the question, how does this reflect against other people that they provide internal audit services for? And they said we are in the upper quartile. So that's a very good reflection on the organisation. Over the last two meetings, they've given us 3 reports on individual areas. One is on risk maturity, quality governance, and data security protection. They have all come out as significant assurance with minor opportunities to change. There are no outstanding recommendations that they've made at all, which is nice to know and actually quite unusual. I should also just say they also made some very favourable comments on the reports that they gave us on risk maturity. They particularly commented on the positive risk culture across the organisation, and also about longevity of risk, which we have in our analysis now, which we only introduced about 6 months ago, I think, but they quite like that. I should also say to people outside the committee, when KPMG report back on minor recommendations, we do take those into account, even though they're not significant. So we do question those and make sure that they are going to be complied with and done in a good timescale, which they invariably are. I could give you an example on each report, but I'm not going to. But I will give you one on quality governance. It was their final minor recommendation, which was about calling to account. And this is their comment was that we, as an organisation, had limited reinforcement for those staff who do not adhere to our policies and procedures. And I think for all three of us, myself, Joe and Steve, we all picked up on this point and said, yes, we can't allow that. And that is a very important item for us. And that we all felt as NEDs that probably we haven't been so good on that in the past, in making sure that people took full responsibility for their actions. So that is a minor recommendation, but I think it's a very good one and a key one for us to make sure that's followed through in additional guidance and training for managers. So they're the three key points that I wanted to mention. Azra, can I come across to you? Is there anything else you want to, have you got any updated news on timetables, etc.?
Yep, so just to say, the first one is the fact that the annual accounts did get signed off and submitted on the 29th, because this report was written before that event had taken place. So they all went through absolutely fine. Just a little correction in the paper on materiality. It quotes 6 million here, but actually the materiality limit was moved to 7.68 million. And that was really in recognition of the fact that we had the provider collaborative and a number of other new contracts come online, and therefore our expenditure increased. The triviality remained at 300,000. So they went through the audit and they reflected it on that basis. In terms of the final element, which is the value for money opinion that needs to be given by Grant Thornton, they're expected to complete the work on that by the end of July, which means that we should still be on track for being able to have the final sign-off and submission of both our annual report and annual accounts well in preparation for the members' meeting, which is scheduled for September. So I'm not anticipating a problem in any element of that timetable. That was it, Steve, unless there was anything that anybody else wants to ask.
Thank you, Azra. And I think Sat had pointed out that materiality change, so apologies that we didn't pick that up. Happy to take any questions.
Suzanne, please.
I'm a little bit puzzled about the example you just gave of calling to account, because it taken in one way, it could sound as the implication is that we should be returning to a blame culture when we blame individuals for not doing things which we tell them to do, as opposed to looking at some of the systems that we have that prevent people from doing the things that we ask them to do. So I'm just curious, could you say a bit more about the sort of things that the auditor had in mind when they referred to that?
Yeah, this I certainly wouldn't describe it that way, and nor did they use that kind of text in terms of a blame culture. It's really just about simply people at all levels of the organisation. People have accountabilities and responsibilities, and if there was a failure to follow the procedures and policies that we lay down, that inevitably has some sort of consequence. And that widely speaking, we were doing the right thing and the staff were, but on a scale of the actions that we take, maybe we could be a little bit stronger, particularly from our managers to staff. But there wasn't anything in there that they were saying we have made a disastrous or catastrophic decision or failure to follow a policy. They would have picked that up elsewhere, and they wouldn't have put that down as a minor recommendation. So it really is about upskilling our workforce and additional training to make it better.
Iffy, please.
Thank you, Andy. Just to add to what Steve was Stephen has said, Jane and I met with the auditors to try and understand this a little bit more. And what they said to us is that they ran a couple of focus groups, one with Bracton staff and the other with Greenwich. And this is something that actually came from the staff, that they felt that we were perhaps not assertive enough in pursuing staff who don't do what they should do. So it wasn't as an organization or saying this is stuff, this is feedback that they got, and this is why in our discussions about how we address this, and Rachel Clare has already mentioned this, we've talked about how important it is for our frontline managers to be supported through the leadership program to have those conversations and begin to think about how they hold people to account for not doing what they should do, which we must do, even though as an organization we want to be supportive and we want to look at systems, right? But we all come to work to do a good job, and we need to work within the guidelines set out both professionally, but also within the teams we work. So I hope that kind of helps you, Suzanne, to understand how this has come about.
It sort of does, but I think it's quite a difficult balance to get right. And I'm not 100% assured that the comments came from staff, because one of the things that sustains a blame culture is staff blaming each other and thinking, oh, so-and-so should have done something and didn't, when they don't understand the circumstances why it was impossible for so-and-so to do something. So I remain to be convinced, as it were, about how the balance is going to be found.
Well, striking a balance with these things is always an issue. And there, as you say, there may be systems issue, there may be human factors. There's no question about that. But similarly, I think that, we have frontline managers, we have middle managers, etc., to make sure that work is done as it should be done, and that's part of where the leadership training, supervision, appraisals of people, all of this come into play. Sometimes when you speak to managers, one of the things they will say to you is that they're quite nervous of doing this, because there might be a complaint, there might be a grievance, and then they're going to be removed and dragged into something that they may never see the end of it. So we just need to make sure that our staff are equipped to do this. And my sense is sometimes it's about telling people early enough and being able to sit with them to understand what the issues are, rather than not doing anything, and then there's a major problem and you're trying to kind of resolve things, and that's where people start pointing fingers. So I don't have any doubt in my mind that across the NHS, not just Oxleas, we need to do a bit more, but it's about how do we help our staff to tackle this in the light of what they see as a lot of work that they have to do.
Thank you, Ife. That's very helpful. If there's nothing more on that, we'll move on to the Board Health and Safety Oversight Committee. Sally, please.
Thank you. We're bringing this paper today following discussions that we've been having over the past few months about getting greater oversight of the health and safety strategy, and therefore the idea is to create a subcommittee for the board on health and safety, and the paper outlines the membership, frequency of meeting, and gives the terms of reference. And we're asking the board today to approve this so that we can set up the meeting, which will run really in parallel with the Workforce Committee. Thank you.
Yeah, thanks, Sally, and thanks for the work on this. It's taken some time for us to get here, but I think we're getting there. Any observations? Nina, please.
Thank you, Andy. You've heard me say this before a few times, but just to reiterate, I think this is really about getting the right people around the table, both execs and non-execs, and the right amount of dedicated time, dedicated reports, dedicated deep dives, and dedicated risk registers to really try and get under the skin of some of the health and safety issues that we know we have been grappling with for a couple of years. And I think having the right people around the table wearing a very explicit health and safety hat will take us a long way forward.
Good. Thanks very much for your energy and efforts around this, Nina. This is for us to approve, colleagues. Do we approve? I see universal acceptance. Well done for all the work on this. I'm very grateful. If we go on now to the board visits, there's no need for too much detail on these, but what I would like is to highlight any particular areas of concern that may have cropped up. I'm looking at the first one, and I'm trying to scan down to see who went to this one.
That was me.
Oh, there we are. Yes, please.
Okay, if we're focusing on any areas of concern, there were none. It was a delight and a pleasure to visit Informatics, and it was great to see all the work that they had done for the trust, but all the work that they had done for a directorate. So well done to Alison and her team. Thank you.
I absolutely echo that. I think they really have grafted, haven't they? And having caused them a lot of pain recently, the various problems that I've had, I think they've been great, absolutely great. Great service, and they've worked really hard without appearing to make any fuss whatsoever. So please, and our thanks go to the team for all of their great work. We don't have to rush too much, folks. If there are things you want to bring up, please bring them up. Jo, please, on school-age vaccinations.
Yeah, it was a really good visit, actually. It's a great team. They've really had to, you can imagine, adapt what they do, because they're the team that go into schools to do vaccinations, etc. And so when we spoke to them, they were sort of getting ready for a real catch up on things. Interesting points they raised. There was no real issues, but they raised some interesting points. One of which I mentioned last time actually was about the whole COVID skepticism about COVID vaccines creeping into further skepticism about school age vaccination. So they felt there need to be some stronger messages there. Clearly, if we start having childhood vaccinations for COVID, that's potentially going to impact them as well. And also, we are still on paper consent forms, and we know that neighbouring trusts are using electronic forms. So there was work going on to see if we could move to largely electronic consent, which they felt would be very helpful. But very good visit, great team.
Thanks very much, Jo. I went to visit the Joint Emergency Team along with Helen at the Woolwich Centre. I just thought they were great. The energy and the genuine partnership work that was going on was really, really good. And we touched earlier about, yes, our teams are tired, but this lot did not look tired. They really did absolutely bubbled with energy. And to have RBG and our people working as one in that building, I thought was really, really good. And one of those visits you come back from, I think that was just great. You feel better after visiting people like that. There's a couple of recommendations on there which Helen has got, but other than that, really good. Sing out if anyone's got any questions. The next one was with the district nursing teams with Helen, Rachel and I. Rachel, do you want to talk about this one?
All right, so I think this is a team that is still under a lot of pressure, but probably is moving in the right direction in terms of things improving. Familiar themes, I think, around referrals, parking, travel, and the amount of time it takes when we've got inappropriate referrals to push back. So we were thinking if there's something we could be doing that's a bit more strategic to help them with that. But really good engagement with the values and with building a fair at Oxleas, and some new managers there as well who are settling in.
Yeah, there was an interesting visit, this one. And in our pre-discussions, we had long discussions with heads and governors around parking, around ULEZ as well. I don't want to go over all of that again, but Matthew, if you could, or somebody, give us a brief update on ULEZ. Parking's parking, but there was an awful lot of discussion we had beforehand. Over to you.
Yeah, I mean, on the ULEZ, we've looked into this, and for any members of staff who have to use their car to enter, so in the first place, this has been coming for a few years, and we do want to see fewer polluting cars on the roads. And as someone who, when I lived in Greenwich, I had to use an asthma inhaler when I went for a run because the air quality was just so stinking. And since I moved out of there, I've never had to use one. So we do want to stop people driving around in polluting cars. What we're planning on doing is, I think, supporting staff who need to travel into the zone or within the zone for the purposes of work. So this doesn't include commuting. But for people who need to use their car within the zone to visit patients, I think we're going to cover the cost of the ULEZ for the first 12 months. I will ask Rachel and Nazra to correct me if I get this wrong, to give them a chance to upgrade their vehicles and get that sorted out. So if you commute into the area, then you won't get that covered, because that would then be a benefit in kind, and that creates all kinds of tax implications, etc. So, you know, if you are commuting, you'll have to consider alternatives or bear the cost yourself. But we will do this as a sort of transitional measure to try to support people to upgrade their vehicles. And on the parking side, it is very difficult. I mean, I think there was some of the board were talking earlier about trying to drive through Greenwich and areas just now. It's very, very hard. So much of the policy around access to some of the patches we work on is very heavily controlled by matters outside of our control. And Andy, you and I met the council this week and did raise this issue with them. You know, it's an important revenue generator for them, and there are many organisations, including unpaid carers, home carers and others, who also have these same issues around parking and these same challenges. And I think it's you know, if you make the case that NHS staff need it, then actually why would you exclude social care staff and, you know, domiciliary care workers and unpaid carers and others? And suddenly a local authority that's already got financial pressures finds itself with an even bigger hole in their budget. So we're just having to do what we can tactically around this. The service directors are doing some work to try to understand exactly what it is their staff need and what groups of staff it is that need support around this, because it's actually by far, I know, you know, it's not a one size fits all thing where we can find a solution for one group of staff that will suit all of them. You know, there's some sites like Elton Community Hospital where parking's far harder than others, where we might be able to do something around that. So I think parking's a constant issue. We had a good win in that Lewisham Greenwich Trust have made available the car park behind Oxleas house for staff who are working in the evenings there. So staff can now park in that car park rather than having to park and walk a distance at night. So that is a positive. So we will chip away at it, but you know, driving in London is very difficult and is becoming increasingly so. And I think we're going to have to continue being open to alternative ideas, recognising for some of our staff they need equipment and they need a car to get between places. And I can see Ian wants to come in.
Yeah, thanks, Matthew. I mean, part of the context, I suppose, of working across 3 boroughs is that we've got different arrangements in each borough. So if you go to Bexley, you're very it's unlikely you're going to have a lot of negative feedback about parking, because health staff are able to get the same passes as social care staff, which enables them to park on yellow lines, etc. Bromley, it's going to be something slightly different, but I think there is a particular set of circumstances that make Greenwich difficult. And I guess just following on from what Matthew's saying, it's whether we can take any more concerted action in conjunction with the local authority. You know, we have good, as I think your visit to Jet suggests, Andy, you know, we've got good working relationships with RBG. It's just not the bit of RBG that's responsible for parking necessarily, and it's just what we can do, if there's any more we can do with that. And I don't know if that's something that Danny has any kind of influence over or not.
Matthew, we didn't get a terribly strong support, did we?
Well, I think they recognise it's a problem, but I think it's one of those issues that no one really seems to know what we can do about it. You know, the council can't afford to lose revenue at a point where their budgets are under huge pressure. You know, some of our staff, they do need a car to get to their jobs. There's others who don't, and who we need to encourage more to use alternative measures. It's I think it's one of those ones that if there was you know, I mean, talking to Rachel Matheson and others about it, you know, each team has slightly different needs. For some people, it's they need somewhere to park so they can work on a site all day. So at Eltham, it's very hard to do that without having to move your car every 4 hours. If you're at Oxleas house, you don't necessarily be walking 15 minutes in the dark at night between different bits of the site. If you're a district nurse, you want to be able to park close to where you're visiting and not be worrying about getting a fine while you're trying to go in and deliver a unit of care and get away. Then again, the council can't do much about private buildings, and I know separately we've had discussions with Bartley Homes and others to try to get that cracked. It's people recognise it's a problem, and we are not able. I've not seen any evidence of us being able to come up with a concerted answer to it, to be quite honest. And I know other trusts in London struggle continually with exactly the same set of issues, particularly the inner London boroughs where parking's a really big problem for us.
Thanks, Matthew. Just on the inappropriate referrals, or if that's the correct word, the referrals, Rachel, that the district nurses were talking about in a pre-chat. I think PQAC is picking this up, but I just wondered if anyone, whether it be Jane or yourself or or Yemisi wanted to talk about that issue, about the referrals going to district nurses that appear to be inappropriate, in the sense that GP referrals and some hospital referrals that mentioned us quite a lot. Jane.
Thank you. This has been going on for a very long time, and most of it is down to people not really appreciating what district nurses do. Historically, they've been just like an invisible sponge, soaking up absolutely everything that happens outside of primary care, GP doors, or outside of a hospital ward environment. They have been commissioned to do very specific things, though. And I think this is where we need to continue to raise awareness and educate the other referrers about what they can do. And I know that there is some work that's happening with some of the district nurse managers at the moment, where they're trying to remind people what we are actually commissioned to do and what the skills are. Obviously, if commissioners wanted district nurses to do more, they would need to invest more into providing more bodies to do this. They can only do what they're commissioned to do, the activity and the skills. So we do need to work as a broader system to see how some of these other things that need to be done but don't fall within the remit of district nursing can be picked up. And I think this is probably going to be a wider ICS issue than just us. But there is some work going on at the moment, and it will probably be work that we have to continue for forever and a day.
Thank you. As you say, we had this issue a while ago with Bexley, which we seemed to fix, and then it came back again. But what they were saying is, when you ring a GP surgery to say this is an inappropriate referral, it takes you 90 minutes to get through, and you could have done the referral by then. You know, so it's quite an issue. As long as we keep this on the agenda somehow, somewhere, so we can come back to it, that will be very helpful. Anything else on the visits? I did go to medical staffing's meeting. It wasn't really a formal visit. Well, they did impress me, and as usual, you find out it's a lot more complicated than you first thought when you go and visit these various teams. So I just wanted to add that one in. I thought they were doing an excellent job as well. Are we done on those? If we are, Council of Governors updates. Sally, do you want to say anything about that?
Thank you. This really just summarises the recent Council of Governors meeting that many colleagues were at, and the election plans coming forward. If anyone has any questions, I'd be happy to answer.
Okay, thanks very much. Any other business from anybody? Right, I can't see any, thank you. Right, we're going to close this meeting now. We have part 2 to deal with. So this meeting now comes to an end, and if we meet again at 14:25, is that okay with everybody? Give 10 minutes to prepare yourself for the next one, which shouldn't last too long. So see you at 14:25, please. Thanks very much.